Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Tnfog Marathon Cme. So let us start the webinar with Tamil Thai Varth. Lamp lighting.
Like this. So, background also.
It's my privilege to introduce the MOC of today's webinar, Dr. Gayatri N. Ma'am. Ma'am is the executive member of Triox. I welcome you, ma'am. And it's my honor to introduce the other MOC, Dr. T. Radhika Gauri, ma'am. Ma'am is the specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good evening, esteemed faculty. Good evening, Sampath ma'am. I request Sampath ma'am to introduce our chief guest. Sahiti, can you play Sampath ma'am's slide? Sampath ma'am, as we all know, she's a candidate.
No problem.
Yes, ma'am.
I welcome you all, our chief guest, Dr. Vidya Topi, and the guest of honor, Dr. Kasturi Donamath, and our Yuva speakers, and our update speakers, and the moderators for the panel and the panelists. See, this is the Marathon CME, which is conducted every second week of the month, and the day is Friday. We have 3 sessions. 2 Yuvas will present the topics. We have the theme as a single topic. 2 Yuvas will give the topic, and we have the same judge, 2 judges. Thanks to Dr. Kartika and Dr. Chanti. And at the end of the year, in the TNFOG annual conference, the best Yuva orator will be awarded. The second is the update of the theme. And third one is the case scenarios of the same theme. So today we have the ectopic infections as the theme. That is the early pregnancy problems. So first I welcome our chief guest, Dr. Vidya Topi. Vidya Topi, CV please. Dr. Vidya Topi is my best friend, and she is the current vice president of our Foxy, and she is the professor and the former HOD of Vijaypur Medical College. And 1 minute, she was the committee chair of Food and Drug Committee, and she got the best committee award. And ICOG governing council member, she was under Foxy Champion Award, and she is the she was Jogi corresponding editor, organizing chairperson of Kasoga.
Thank you, Sampath. That is enough.
And she has many publications, and most of her publications has got the award. She did one publications with the nutrition, and I also had the opportunity to write a chapter in that book. Welcome, Dr. Vidya. We need the blessings and wish well for the success.
Yes. I really congratulate the President TNFOG, Dr. Vidya Prabhakar, and our most dynamic Dr. Sampath Kumari. Wherever I meet Dr. Sampath Kumari, always the energy, enthusiasm flows, and I get inspired from her. So she is my mentor also and follower also. I have witnessed this when she came to Bijapur for the adolescent. See, adolescent, we did a
Rally.
walkathon, a rally we did, and we in Kasoga conference, she was very much there with me. So in my Foxy journey, Dr. Sampath is always there with me, and I wish her journey to be better and better, and she should win this presidential election. Second thing is about this marathon CME. I was part of this marathon CME when I was a Kasoga president, and I like the whatever the scientific content of today. The UAs who are taking part in this, UAs, they are talking on various topics, and they are being incentives is they are getting the prizes also. So panel discussion is very, very, I think, interesting one. And two UA sessions where Dr. Ratna Arumugan and Dr. Nazia are talking on pre-implantation, genetics, and infections. So I'm eager to listen to also. So all the best for the academic sessions, as well as all the best to Dr. Sampath Kumari. All of us together, we will make all the efforts to see that Sampath Kumari is a president. Thank you very much, organizers and all the team members. Thank you very much. Thank you,
Thank you,
Sampath, again. Thank you.
Thank you, Dr. Vidya, for the nice words.
Yes. Thank you. Thank you.
Thank
Yeah,
you.
yeah. Thank you. Thank you. We'll meet
Thank
soon.
you.
Thank you.
Yeah, sure. We will meet within 2 hours.
Yes, ma'am.
Sampath madam, you're muted. Okay, ma'am.
Yes. Dr. Kasturi madam has joined?
Not yet, ma'am.
Not
She
yet.
said she will
Whenever she
join.
joins,
I
we will
spoke
get
to
that
her.
wishes. Dr. Kasturi madam is our past president of Kasoga and HOD of KIMS. Whenever she is joining, we will get the blessings and wishes from
Okay.
Dr. Kasturi. Radhika,
Okay,
now
ma'am.
you proceed with the scientific session. I
Okay,
think
ma'am.
our judges and the UAs are there. Okay, you take
Okay,
over.
ma'am. Sure.
Thank you, Dr.
ma'am.
Vidya. The Kasturi madam will join soon.
Okay. Thank you, Sampath
Thank you,
ma'am.
madam.
Thank you for the opportunity. Thank you, ma'am. So we'll start the scientific session. I invite Dr. Shanti ma'am, who is a professor of Department of Obs and Gynae, Savita Medical College and Hospital. And she has done her MBBS from Madras Medical College and MD from IOG, again from MMC. She's trained in ultrasound in OB-GYN, advanced infertility, advanced laparoscopy. She's an also provider and instructor course she's done. She has more than 25 publications, and her field of interest is endoscopy, high-risk pregnancies, and adolescent gynecology. She is an UG and PG examiner, and she's an invited faculty in various conferences, both national and international. She also has credit of organizing various conferences. Welcome, Shanti ma'am. Now we have
Madam, Radhika madam, Dr. Kasturi has joined.
Ma'am has joined. Yeah, welcome,
Yeah.
Kasturi ma'am. I will introduce.
Yeah, well,
Sampath
yeah.
madam,
I
are
have
you here?
We will call Sampath ma'am. Yes, ma'am is here.
Yes, ma'am. is here.
Sampath ma'am. Dr. Kasturi ma'am is here, ma'am. Our guest of honor.
Hello.
Welcome, Kasturi ma'am. Good
Yeah,
evening.
yeah, thank you. Yeah, good evening, good evening. I had little network issues, little traveling.
No problem. No problem. Very warm welcome to you, ma'am.
Sure, sure,
Session.
sure. Very happy to be a part of this webinar series.
Thank you so much for your precious time.
Sampath,
Yes, ma'am is here.
Sampath madam seems to have a
she's
little problem
muted.
with this. She's now unmute. She's muted.
She's muted. Just
Okay, Radhika, we'll introduce madam. Uh,
1 minute. Sampath ma'am. Dr. Kasturi ma'am is our past president. Ma'am, Madhukana madam, Kasturi ma'am. Okay. Okay, ma'am. So Dr. Kasturi ma'am, we welcome our guest of honor, Dr. Kasturi ma'am, who is a past president Kasoga, director of Tatvarsha Hospital. She's a ex-HOD Department of Obs and Gynae, KIMS Hubli, and she's also an ex-president HDOGS and ex-secretary general of HDOGS, and she's a principal investigator for international research projects, MCI inspector to colleges all over India, and UG and PG examiner at many universities. She's a chairperson of graduation committee, KIMS Hubli, and she was a TOT trainer, faculty at many state, national, international conferences, and a Rotary member, conducted Jnana Harsha Kasoga PGCME for the last 6 years. She's conducted many workshops, CME and conferences, and contributed chapters to many books. Welcome, Kasturi ma'am.
Yeah,
for,
very happy to be a part of
Please
Welcome,
bless
Dr.
our
Kasturi, madam.
meeting.
Yes, madam. I think you are also traveling. Like, hello.
Yes,
Uh,
ma'am.
Very happy to be a part of this webinar and under the leadership
We
of
are
Sampath
happy
Kumari
to have
madam.
Dr. Kasturi as our
Yes.
guest of honor. Madam,
Yes.
I think you would have come from the college now only.
Yes.
Yes, madam. Kasturi, madam. You can
Yes, madam. Very happy to be a part of this webinar series, and then we wish all the best for Sampath Kumari madam. We want everyone's support for madam in future. Yes, madam.
Yes, ma'am. So
Thank
we
you
will.
so much, Dr. Kasturi, madam. I'll meet you now.
Yes,
On the
we'll
way
be
to your
meeting.
place.
Yes, madam.
Okay.
Yes.
Thank you.
Yeah.
We will. So we will introduce Dr. Karthika ma'am. I invite her, who is the professor of SRM Medical College Hospital and Research Center, Katangulathur, and she has done her MBBS from MMC and MD from JIPMER. She is an undergraduate and postgraduate teacher. Special interests are high-risk pregnancy, gynae, endoscopy, midlife health, and she has won numerous awards. Dr. A.V. Uma
I will start the program.
But still, as ma'am said, you are a motivation, inspiration to the other young gynae doctors. So I also invite Dr. Madam, can you please introduce Dr. Ratna Armugam, who is a speaker?
Our first speaker is Dr. Ratna Armugam. She is doing fellowship in fetal medicine in Trichy Fetal Medicine Center. She is going to talk on pre-implantation genetic testing.
Good evening, ma'am.
Ma'am, please make it as full screen, ma'am.
Yes.
Yeah, now we can see. Thank you.
Good evening, ma'am. Today topic is pre-implantation genetic testing. Pre-implantation genetic testing is an option for couples to reduce their risk for genetic disorder in pregnancy by using IVF and genetic testing or screening. Implanting only embryos that are not expected to have a genetic abnormality of concern. Requires IVF and genetic testing of embryos. PGT terminology, a test performed to analyze the DNA from oocyte, polar bodies, or embryo, cleavage stage, or blastocyst for HLA typing, or for determining genetic abnormality. Types of PGT: PGT-A for aneuploidy, M for monogenic or single gene condition, SR for structural chromosomal rearrangement, HLA for HLA typing, and PGT-P for polygenic disorder using polygenic risk score analysis, PGT for mitochondrial disorder. Then clinician preference recommended for PGT-A is advanced female or maternal age, recurrent implantation failure, recurrent miscarriage. In PGT-A for recurrent miscarriage without a genetic cause is not recommended in a recent evidence-based guideline. Recommended for PGT-M based on 2023 ASRM committee opinion for pediatric indication, preferred use severe untreatable or life-threatening childhood onset condition. Rationally clear benefit in preventing serious disease with no effective treatment. Examples like cystic fibrosis, Tay-Sachs disease, spinal muscular atrophy, and Duchenne muscular dystrophy. Serious adult onset conditions like generally supported when the condition is serious, no effective intervention exists. Example like Hutchinson's disease, early onset Alzheimer's disease, hereditary breast or ovarian cancer, BRCA A or 2, when risk is high and managed option are limited. Mild or limited risk, controversial or optional. Mild phenotype, low penetrance or uncertain recurrence risk, variant of uncertain significant. Decision factor, how the variant of uncertain significant was identified, family segregation data, clinical documentation, and patient risk tolerance. Example, late onset, mild form of hereditary hemochromatosis, low penetrance cancer predisposing variant. Non-recommended for PGTM, not appropriate when autosomal recessive carrier status only, no symptom, combination of variant not associated with disease, pseudo deficiency allele, somatic only variant. Example, carrier of one CFTR mutation without disease expression. Benign pseudo deficiency alleles in lysosomal enzyme gene. Recommended for PGT-SR, balanced reciprocal translocation. Example, a woman carries a balanced translocation between chromosome 4 and 11. Risk, embryos may inherit an unbalanced segment, leads to miscarriage or a congenital anomaly, like Robertsonian translocation, inversion, peri or paracentric inversions, recurrent pregnancy loss, infertility with known rearrangement. Clinician preference for PGT-HLA typing. PGT-HLA is considered when couple already have child affected by the condition that can be treated or cured with a stem cell transplantation from an HLA-matched sibling. Conditions like malignant disorder, example leukemia, genetic disorder, treatable with stem cell transplant, example thalassemia major, sickle cell disease, Fanconi's anemia. PGTP, polygenic risk score, provide probabilistic rather than deterministic prediction of the disease risk. There is uncertainty about the accuracy and reliability of this score, particularly recording the predictive value across a diverse population and in relation to complex multifactorial disease influenced by both genetic and environmental factor. PGTP remains a nascent and unproven technology that is not recommended for clinical use and should not be offered as a clinical service at this time as ASRM committee opinion. PGT for mitochondrial disorder. PGT for mitochondrial disorder is not indicated in cases of homoplasmy. Reason, if all mitochondrial DNA copies are mutated, there is no possibility of selecting an embryo with reduced or absent pathogenic load. PGT is useful only in heteroplasmic mixed population of normal and mutated mitochondrial DNA, where embryos with lower mutation load can be selected. PGT requirement. In addition to IVF, PGT requires test setup, embryo biopsy, genetic testing of biopsed cell, and cryopreservation of embryos. Biopsy lab equipments, inverted microscope, additional requirement like stereoscope for transferring oocyte and embryo, incubator adjacent to the work area, specialized equipment, laser system for assisted hatching and blastocyst biopsy, certification, CE for mark recommended for all equipment considering local legalization. Biopsy laboratory materials, capillaries, IVF certified dishes, IVF certified mineral oils, buffer media, HEPs and MOPS media. Micropipette differ according to a biopsy stage. The holding pipette can be the same as for ICSI or with one adapted diameter can be used. Biopsy pipette has a special diameter according to the biopsy stage. 10 to 15 micrometer for polar body biopsy, 30 to 35 micrometer for cleavage stage biopsy, 25 to 30 micrometer for blastocyst biopsy. Methods of oocyte and embryo biopsy and time of biopsy. On day 1 or 0, polar body biopsy can do. On day 3, cleavage stage biopsy. Day 6, blastocyst biopsy. Polar body biopsy method. Position. First, we have to position the oocyte with polar body. Both polar bodies aligned in one focal plane. Precise opening is introduced by 2 to 3 laser shot. Through the opening, the blunt biopsy capillary can be introduced to aspirate the polar bodies, which can then be released in a separate droplet in the same dish for the further processing. Limitation: cannot detect the paternally derived mitotic error or pathogenic variant. High workload due to biopsying all oocyte and zygote. Moderate risk to technical complications like polar body fragmentation and degeneration. Then blastomere biopsy, that is first it is due we will do in day 3. First, we have to prepare the biopsy medium, zona pellucida opening, visualize the nuclei, then biopsy, handle the biopsy result, rinse with biopsed embryo, culture and transfer the embryo, and then balance embryo, we have to cryopreserve it. Limitation cannot estimate the mitotic error leading to chromosomal mosaicism. Limited DNA amount due to single cell analysis. Estimated rate of inconclusive diagnosis is less than 10%. Key aspect performed on day 3 involve collecting the single blastomere. Diagnostic capability can detect mitotic error from both partners. Blastocyst or tocoectodermal biopsy method. This is we can do on day 3 or day 4 or day 5. In day 3 hatching, we have to do the laser hatching of the day 3 embryo and wait till the day 5 or day 7 to cells released spontaneously. Same thing we can do in morula stage also on day 5 also. Blastocyst biopsy method. Prepare the biopsy medium. Position the blastocyst. Placed inner cell mass between 7 to 11 o'clock position away from the zona pellucida opening and suction by the holding pipette. Then zona pellucida opening. Aspirate the tocoectodermal cell. Use gentle suction to aspirate 5 to 10 tocoectodermal cells into the biopsy pipette. Excise the tocoectodermal cell. Use laser pulses to excise the cells. Minimize the cell damage. Verify the biopsy. Ensure 5 to 10 tocoectodermal cells are biopsied. Prevent and cross-contamination. Change the biopsy pipette for each blastocyst. Thoroughly rinse and verify the effectiveness. Post-biopsy handling. Immediately transfer the blastocyst to the culture media or cryopreserve. Limitation, technical and methodological limitation. Detection of mitotic error leading to chromosomal mosaicism may be limited by technique, validation parameter, and sampling bias. Cryopreservation mostly mandatory due to the turnaround time of testing strategy. Key aspect multicellular section. 5 to 10 cells collected from the tocoectoderm on day 5 to 7. Higher reliability, different approaches, various biopsy strategies with varied learning curves and skills. Benefits: higher DNA amount, multiple cell fragment analysis provide more DNA, lower inconclusive diagnosis rate, efficient analysis, detection of mitotic error. Consideration: laboratory workflow requires planning multiple time slots for on day 5 and day 7, and efficient cryopreservation program, skill and expertise, embryo selection. Only embryo reaching the blastocyst stage are biopsied, which may reduce the number of embryos available for testing. Minimally PGT. This is blastocyst fluid aspiration. DNA collected from fluid inside the blastocyst cavity. Avoid removing the cells. Technically challenging and limited DNA yield. Pros and cons are that pros: improved accuracy, higher implantation rate, lower rate of mosaicism, less invasive strategy, simple method without the required expertise. Cons: risk of damage to the embryo. DNA may originate from the necrotic or apoptotic cells. Higher false positive or negative result. Variation of heterogeneity in technical expertise. Costly technique. Non-invasive PGT, NIPGT. Spent culture media analysis. Detect the cell-free DNA released by the embryo into the culture media. No biopsy, embryo remains intact. DNA may be fragmented or contaminated, lower accuracy. Pros are border selections, reduce the technical issue, non-invasive sampling technique, decreased influence of mosaicism, lower danger to the fetus, improved effectiveness and convenience, possibility of ongoing observation. Cons: lack of ability to determine the cell ploidy, restrict the embryo depletion, decrease susceptibility, standardized issue, increased incident of false positive and negative rates, elevated level of contaminant and noise, technological constraints, and legal and moral concern. Sample collection. After the biopsy cells are washed, either fixed on slide for the fish analysis. As a genome-wide technology began to replace the fish method over the past decade, this technology required whole genome amplification as a first step. Tubing has become the most widely applied method for collection of biopsy sample. Tubing. Tubing is what is tubing? A 2 microliter of the biopsy solution or media will be there. It should be maintained in minus 20 degrees Celsius. Transport the biopsy cell from the embryology lab to genetic lab to reduce the other contaminations. Cryopreservation of biopsied oocyte embryos. Oocyte or embryo may be frozen at various stages before biopsy, after biopsy and diagnosis. Vitrification is recommended, applies to the biopsed and non-biopsed embryo. Key consideration: biopsy embryo must be vitrified individually with proper labeling and witness. Multiple vitrification warm cycle may be necessary, but their impact and outcome needs further investigation. Center-specific policy: each center should be decide its own cryopreservation vitrification policy based on experience and performance. Genetic testing: polar body, that is a single cell analysis, and blastomia is a day 3, that also single cell analysis. Tocoectoderm, that whole genome analysis. Evaluation of genetic analysis method in PGT, PCR are fish first 1991-1995 it is introduced. Advantage, detect the specific mutation or chromosome, simple and quick. Limited scope, only known targets, low resolution. Preferred in monogenic disorder and aneuploidy screening. Array comparative genomic hybridization introduced in 2008. Genome wide copy number detection, 24 chromosome analysis. Advantage, limitation, cannot detect the balanced translocation, moderate resolution. Preferred in PGT-A and SR. Quantity polymerase chain reaction introduced in 2010. Advantage, quantitative, faster than ACGH, detect CNB. Limited multiplexing, less comprehensive. Preferred in rapid aneuploidy screening. SNP, single nucleotide polymerase microarray, introduced in 2012. Advantage, family-based linkage, detect inheritance pattern. Limitation, requires parental DNA limited to de novo mutation. Preferred in PGT-M HLA typing. NGS, next generation sequencing, introduced in 2014. High resolution, detect SNV, CNV, mosaicism, and mitochondrial DNA. Limitation, costly, complex data analysis. Preferred in all PGT types, M, SR, A, and HLA.
Ratna, you are exceeding the time.
Ma'am, 3 more slides, ma'am. Scope expansion from single gene, full genome, resolution, low fish to high fish, and NGS. Preferred modern method NGS, comprehensive and accurate, adaptable. Complementary use, ACGS and SNP arrays still valuable for specific indication. Counseling and informed choice, we have to relevant documentation, general counseling, IVF and genetic counseling should be appropriate. Ethical practice of PGT in India requires strict adherence to ART and PCPNDT Act, transparent counseling and documented consent. Form G serves as a model for invasive procedure, while IVF and PGT clinic must ensure that their consent form covered procedure details, risk, embryo fate, and legal compliance. Recent study, the misdiagnosis of different type of aneuploidy for PGT, a systemic review, meta-analysis. Total 22 studies were included to assess the discordance of tropoectoderm biopsy and inner cell mass or whole blastocyst result. The discordance rate of euploid embryo diagnosis is low, 2.6%, where it was significantly higher aneuploidy embryos, 9.2. Segmental aneuploidy showed highest discordance rate, 7.4%. In a PGT-A population, misdiagnosis of segmental aneuploidy embryos was particularly prominent. Reclaiming abnormal embryo after the pre-implantation genetic testing for aneuploidy, the patient perspective and transferring the embryo against a prior institutional advice. Among 21 participants, transfer outcome included 6 healthy births following a transfer of embryo labeled abnormal, 1 ongoing, 4 first trimester miscarriage, 1 chemical pregnancy, 12 failed implantation. Conclusion: empower the family, improves the IVF success rate, reduce the trauma, specialized and evolving. Limitations are not 100% foolproof. Potential for mosaicism and small risk of to the embryo exists. Still expensive, not universally available. Thank you, ma'am.
Good presentation, Dr. Ratna. So you have explained in depth about how PGT is being done. Can you just tell the main indications for doing PGT testing?
PG, first we have to do for genetic screening, ma'am. Already we have diagnosed some genetic problem is there. Now we can do, ma'am.
Okay. So
Embryo selection, this is free from baby, ma'am.
Any other indication you want to do?
If already
for like recurrent abortions, recurrent miscarriages, IVF failure, any other indication you want to do?
Yes, ma'am. PGT-A we are doing for recurrent implantation failure and.
So mainly PGT will be indicated when there is a genetic disorder in the family, when there is previous IVF failure, recurrent miscarriages, and whenever she is having some carrier status for inherited disorders, right?
Yes, ma'am.
Okay. Suppose you are doing PGT, whether you want to do first trimester screening still?
No need, ma'am.
Does NT scan had any other value apart from chromosomal problems?
Fine.
whether it is required or not required.
It's not required, ma'am.
See, some structural problems you can pick up by NT scan, right? NT scan is not only for finding out risk for chromosomal problems, no. So we are able to pick up other structural anomalies.
Yes, yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. Shanti, you're mute.
Shanti ma'am, you are not audible, ma'am. Have you connected to any earphones or something like that, ma'am? Or else you can try joining from mobile, ma'am.
It's okay. Continue.
Ma'am, now we can hear you, ma'am.
Shanti, you're audible.
Oh, okay, fine. Okay. So, what is the type of genetic testing you do, like upon the thing, whether it is NGS or in the recent days? What is the advantage, main advantage between using NGS and chromosomal array?
Ratna ma'am, are you there? Ratna ma'am?
Yes, ma'am.
Yeah, ma'am has asked the question.
So
Yes, ma'am.
basically, recently, what is the sequence you are using, whether it is NGS or chromosomal array?
Chromosomal array we are using, ma'am. Both.
So is there any specific thing, when do we use, what are the advantages of this and that? You have elaborately enlightened about that, but anything specifically?
Microarray we are doing routine clinical screening, ma'am. NGS
Okay.
for few mutation rare variant detection, ma'am.
Oh, fine. Okay, no problem. We can move on to the next. Yeah.
Okay, ma'am. Thank you, ma'am.
So next we have Dr. Nazia Sheikh. So who has completed her MS in Andhra Medical College and MBBS at Andhra Medical College, and she has completed her fellowship in reproductive medicine at Ramchandra Medical Center. And her professional experience is that she has worked at Metho Hospitals and worked at Sri Ramchandra Medical College. Yeah, so we move on to hear from you, Dr. Nazia, upon the
Good evening,
fetal
ma'am.
infections. Yeah.
Good evening, ma'am. Good evening, everyone. I'll directly share my screen and start my presentation.
Yeah.
1 second, ma'am. Manzoor.
Nazia, internet இருக்குல்ல இது நமக்கு இருக்கு. Nazia, Dr. Nazia, உங்க இதுல வருது.
Ma'am, at first open the PPT, ma'am.
Hello, ma'am. Are you able to?
Nazia, ma'am.
Ma'am, 1 minute, ma'am. There is technical difficulty. I'm trying to share my screen, ma'am.
Okay.
Ma'am, hello, ma'am.
Yes.
Ma'am, unable to share the screen, ma'am. Can I send PPT? Can I share with someone?
Okay, ma'am. But once try, ma'am. Like, at first open the PPT, ma'am, and click on share,
Okay.
and then click on the entire screen tab, and then click on share again.
I open PPT, ma'am. Yes.
Okay,
Share.
and then minimize it. Come to Zoom.
Okay, I came to Zoom. Yes, ma'am.
And then click on share option.
Share screen. Yes.
Yes, yes. Click on that, ma'am. And then again on top there will be like entire screen tab. You click on that and click on share option. After clicking share screen, you need to click on share option, which is in blue color.
Still, I'm not able to share, ma'am.
Okay, ma'am. Okay, okay. You can share in the group, ma'am.
Yes, I'll share in the group, ma'am. That's much better.
Okay, ma'am. Radhika, ma'am, please share it with me, ma'am.
Ma'am, can you see my screen, ma'am?
Yes, ma'am. Now we can see, ma'am.
Okay, I'm really sorry, ma'am. I apologize. This was really unexpected. Okay, I'll just start my PPT straight away. So today I'm going to discuss a briefly like infections, especially in early trimester, first and second trimester, because most of the infections, some might lead to dangerous congenital anomalies where we have to pick up early, and we like ultrasound diagnosis or the serological test, and the proper cure will prevent congenital anomalies in the baby. And okay, so usually the mode of transmission of all these infection might be transmit placental, bloodborne, or the case is PROM, ascending infections, especially like chlamydia, Neisseria, or UTIs. Those infections after the rupture of membranes they might transmit. Then intrapartum and the horizontal infections. So today I'll be briefly discussing about the torch infections. In that, basically toxoplasmosis, rubella, and CMV, which are highly a major terrorogenic risk to the pregnant population group. So toxoplasmosis, it is an intracellular protozoa where everyone we knew. These days it is less common. All this torch infection which cause a sporadic abortion. It never caused recurrent pregnancy loss. That point I wanted to emphasize. It never causes recurrent abortions. But that episode, like that pregnant lady, if it is not treated, it might lead to sporadic abortions or anomalies. That's why treatment of that particular infection in that period is important. Humans might acquire by eating raw or inadequately cooked meat and improperly washed fruits. You know that usually deleterious effects are there, especially in the third trimester, in which transmission is 60%. First trimester, it's only like 5 to 15% transmission. And that effects of newborn will be low birth weight, hepatosplenomegaly, jaundice, hydrocephaly, convulsions, microcephaly. See, all these torch infections will have a similar clinical presentation on ultrasound. That's why a right diagnosis of PCR and serological tests are more important. Then universal screening for this is not usually recommended because this is not the incidence is much less in Indian population. However, if you have a pets or involved in gardening works during pregnancy, we do have to do. And if HIV infected women also, we consider this. Diagnostic is positive IgG or the negative IgM. It rules out, it indicates old infection, and the active infection can be picked up by positive IgM or the IgG avidity test. Some ultrasound markers, this is common for all, like hydrocephalus, calcification, the liver calcification, ascites, early onset IUGR can be picked up in the as early as 16 to 18 weeks. And how do you manage this? Suppose known case of toxoplasmosis can be treated easily by giving sparamycin 1 gram 8 hourly. Almost the transmission is reduced to 80%. And for the treatment of fetal infection, pyrimethamine can be added 50 mg daily. It should be continued throughout the pregnancy. Okay. And infection diagnosed early in pregnancy using positive PCR test and picked up by ultrasound markers. If at all any ultrasound markers is positive and PCR test is positive, termination of pregnancy is strongly recommended. Then coming to rubella, which is a German measles. It's an RNA virus transmitted by respiratory exposure. And mother can have a sandpaper-like rash all over the body and generalized lymphadenopathy, joint pains, fever. And And how does it cause? See, usually like rubella causes congenital rubella syndrome, especially in the first trimester, like 11 in below 11 weeks. If the mother is infected with rubella, then the congenital rubella syndrome with the triad of cataract, cardiac anomalies like PTA, deafness, and microcephaly, especially that profound mental retardation, developmental delay might occur. So if a pregnant lady with like diagnosed and confirmed rubella below 10 weeks, a strong recommendation of termination of pregnancy is considered along with interval vaccination. And what about 13 to 16 weeks? Still it is affected, but to 40%. And after 16 weeks, there will be extended rubella syndrome with panencephalitis and hepatosplenomegaly, like in other cases. So how do we screen? It's indicated when there is ultrasound features of congenital rubella syndrome, especially the microcephaly or the PDA or specific anomalies like calcifications. Accurate IgG specific IgM positive is a specific. Then how do you diagnose fetal infection? PCR on chorionic village sampling, amniotic fluid sample, or the chondrocentesis. And see, if diagnosed at below 10 weeks, we have to terminate the pregnancy as discussed. And even below before 20 weeks, if we see ultrasound features of congenital rubella, termination is advised. And then interval vaccination. Actually, MMR vaccine is given to all infants as a part of routine pediatric immunization. If it is not covered in infancy, adults and girls and the women, reproductive women planning for pregnancy, after checking their IgG antibody status, should get vaccination before the pregnancy, and pregnancy is delayed for 1 month minimum. It's given safely to breastfeeding women also. Next, our next topic is cytomegalovirus. It's also one of the teratogenic virus. It's a group of herpes viruses, and the primary infection usually is a transplacental spread. Perinatal transmission can also acquire to cervicovaginal secretions and infected breast milk. The thing is, again, there is also a triad in cytomegaloviral infection. Microcephaly and the intracranial calcifications are more specific to this. Choroidoretinitis, like eye infection, which is also major anomalies in this. So CMV infected infants may excrete virus through urine and nasopharynx for up to 5 to 7 years. This picture shows a triad of deafness, then microcephaly and mental retardation. Treatment with ganciclovir, usually ganciclovir 600 mg given the pregnancy might prevent, but no vaccine is available for prevention. So early detection using PCR and also ultrasound features will help in deciding termination of pregnancy. Then HSV, herpes simplex virus. We know it is of two types, HSV1 and 2. HSV1 usually it's orogenital infection and orogenital what is called as vesicles. HSV2 is genital and sexually transmitted. It either can occur as a primary infection or by recurrence. Usual symptoms are fever, myalgia, headache, like no specific thing. Like if it is HSV2 genital infection, you might have dysuria and vesicles around genital region. And intrauterine transmission is also less common. And then herpes infection before 20 weeks means early pregnancy. There are chances of miscarriage and malformations as coinciding with CMV virus, like microcephaly will be there. Pneumonitis is more common. Lungs are more infected in the case of a newborn. So after 20 weeks, it might lead to IUGR, PROM. It's a main concern. If it is a severe form in newborn, it might lead to encephalitis apart from pneumonitis. So we should pick up again in the ultrasound, like early scans using like a targeted anomaly scan. We have to look for microcephaly, non-immune fetal hydrops, because the placenta will become endartereal, inflammation will be more. And then management, antepartum management includes pain relief of the vesicles and antiviral drugs such as acyclovir, valcyclovir 200 mg. Acyclovir we should give 400 mg 3 times a day for 7 days continuously. So we have to complete the course. So usually a cesarean delivery is recommended when there is an active infection, not for non-genital or healed infections. We won't usually do it. And for the newborn baby, again, acyclovir drops are given orally, 0.5 mg per kg for the next 5 days. Coming to next infection, this is chickenpox, varicella. our main concern will be the super infection, bacterial super infection, which leads to pneumonia in this mother and the newborn babies. If the it also depends, severity depends on the period of gestation. Like if it is infected in first and second trimester, then fetal varicella syndrome and prolonged neonatal herpes zoster might happen. If it occurs like 2 weeks before the delivery, then neonatal chickenpox is the outcome. And within the delivery, 5 days before or 5 days after the delivery, then disseminated chickenpox with septicemia and mortality is more. This is the point, and this is the place where we have to thoroughly monitor and reduce the transmission. Like delivery before 5 days and delivery after 5 days by giving acyclovir, acyclovir both to the baby and mother. And then congenital rubella syndrome. Actually, it occurs when the infection occurs transplacentally before 20 weeks. Baby usually have hypoplasia of limbs, IUGR, then microcephaly, and skin lesions. Skin lesions will be like this transplacental infection, and it's a severe form. Again, the newborns might have a varicella infection in the neonatal period, so treatment will be acyclovir. And then next, my topic will be human immunodeficiency HIV infection. I'll try to cover as much as possible. So this infection leads to, it's a disorder of immune system which makes the individual susceptible to infection. Prevalence among pregnant ladies is 0.3, and if treated, the transmission risk is left treated, transmission risk is reduces. Interventions such as high active antiretroviral therapy during antenatal and intrapartum period, and also the delivery by elective cesarean section, avoidance of breastfeeding if disease is active, reduces the PPNCC from 25% or 30% to less than 2%. Means if we follow all antenatal period, intrapartum period, immediately after delivery, neonatal prophylaxis, and also avoiding breastfeeding, will reduce transmission to less than 2%. The few modes of transmission are transplacental, unsafe sexual practices, and the blood route. This is a brief pathogenesis how HIV is infected. As we know, like it goes and attaches to T lymphocytes, especially CD4, which actually it's a fight with other bacteria, virus, and certain malignancy. The virus will produce multiple copies of itself. It takes host cell, it damages the host cell and integrates with the DNA of the host cell. What happens that gradual depletion of CD4 cells occur, and the failure of also B lymphocytes to produce antibodies. So finally, our immunity and overall antibody production capacity will reduce. This leads to progressive loss of immunity and development of acquired immunodeficiency syndrome, which is a group of diseases. It is not a single disease. So primary infection, after the acquiring primary infection in 3 to 6 weeks, there will be acute prodromal syndrome where you have fever, loss of weight, and other generalized lymphadenopathy. Then there will be immune response where you can see antibodies produced to core antigen, and the patient might feel better during this immune response period. Finally, followed by after a latency period, he will have full-blown AIDS. And perinatal transmission, vertical transmission is about 14 to 20%. It's more with HIV-1 than compared to HIV-2. Transplacental transmission occurs 20% before 36 weeks, 50% before delivery, and 30% during labor by if the child swallows amniotic fluid, or especially during labor. So this point, especially this 50 and 30%, where we have to focus mainly on this. And pregnancy effects of HIV. Pregnancy as per se has no effect on disease progression. Only this in the early pregnancy there is increased risk of abortion, prematurity, IUGR, and maternal mortality and morbidity are not increased by pregnancy as such. Only depends upon CD4 count and the viral load, HIV viral load. And clinical presentation from the primary to till the latent period we are discussing. Initially they'll have generalized symptoms of fever, malaise, headache, lymphadenopathy, followed by a immune period, and then opportunistic infections will happen like candida, tuberculosis, pneumocystis carinii, And finally, after a period of 10 to 15 years, the patient may land up with certain carcinomas like Kaposi sarcoma. So median time of infection to AIDS is usually 10 years, and it also depends on CD4 count. So diagnostic, as everyone know, HIV RNA PCR, and screening test is by enzyme immunoassay polymerase chain reaction. Western blot is a confirmatory test at any gestation age. Now, our concern is antenatal management. So, besides routine obstetric history and history relevant to GI tract or respiratory, in any history of exposure, unsafe sexual practices, those also we have to elicit. And then investigation should cover everything, including CD4, CD8 count, LFT, RFT, because they might be on HRT drugs, and then pap smear, MON2 test. Then CD4 count should be periodically repeated every time. And well-being of antenatal women will include iron calcium supplementation, nutritional supplements, and vaccination against HBs, AG, C, and also influenza viruses, certain H1N1 viruses. So what is more important is CD4 count. We follow the patient with CD4 count. If the mother's CD4 count is more than 350, doesn't need therapy for herself, but we have to follow like if the count is, and if any symptoms or the count is less than 350, we need highly active retroviral therapy. So what does this HIV drugs include? It includes 4 kind of drugs: NNRTIs like zirobutrin, zalcitabine,
Can we
lamivudine.
please conclude the session quickly?
Yes, ma'am.
Yeah.
And NNRTIs, nevirapine and delavirine, protease inhibitors, and then entry inhibitors. Among this, so I want to discuss about high active ART therapy. If the count is less than 350, further NACO has revised the guidelines. All HIV infected pregnant or breastfeeding mothers should initiate on lifelong ART at any stage, regardless of count, current guidelines. In this regimen, 3 drug option is recommended: tenofovir, lamivudine, and efavirenz is given. It should be continued lifelong for a mother, and neonates, nevirapine should be given at birth and until a minimum of age of 6 weeks. After that, neonate has been neonate has to be followed for 12 weeks. And then how do we manage patient in labor is we have to give ARV prophylaxis during labor, then minimal vaginal examination, and ARM should be avoided to prevent PP and TC, and if needed, elective LSCS to be done for obstetric indications. And it should not be indicated for prevention of mother to child. Current indications, a current guideline. So the rate of transmission to child is considerably low following vaginal delivery if the mother is already started on ART and count CD4 count is high. Then postpartum management, again, the drugs have to be continued. Breastfeeding can be given. In that breastfeeding also, this we have 2 types, like exclusive breastfeed or replacement. Women receiving ARV can give exclusive breastfeed, and the replacement feeding is given. This completely eliminates the child is negative and prophylaxis has not started during labor, and we have to reduce the viral load, or viral load of mother is more, then replacement feed is given. For contraception, PPIUCD is recommended, or sterilization if the family is complete. Then we have discussed about newborn prophylaxis, then counseling, pre-pregnancy and early pregnancy counseling. The counselor should provide up-to-date knowledge for the patient to take an informed choice whether to which type of mode of delivery, and continue the drugs and regarding the baby. And the other viruses, which include influenza virus, they are not much common, but they only present as fever, cold, malaise. Usual treatment will be oseltamivir 75 mg. 75 mg should be given for 5 days BD. And influenza inactivated vaccines, which are safe in pregnancy, can be given in 2nd and 3rd trimesters. And,
Doctor, your
Yeah.
time is up.
Yep.
Please conclude.
okay, ma'am. Another 5 minutes, ma'am. Sorry for
No,
the
5 minutes is quite.
Okay, ma'am.
Uh,
A few more slides,
one
ma'am.
more minute, ma'am. 1 more minute. Madam, is that okay?
Ma'am,
Guys,
actually, for the UA session,
yeah,
the
we
main
have
time is also one of the things for which they are marked, ma'am.
Yeah.
Yeah, you are given only 12 minutes for presentation, 3 for discussion. You've already overshot it. Try to conclude, ma'am.
Yes, ma'am. Sure, ma'am. Okay, COVID-19 in pregnancy, this has become a global pandemic during 2020. Route of transmission is respiratory route. Incubation period is 5 to 7 days. Currently, no evidence is there, like effect on fetus is not much clear. And current recommendations are directly wanted to go in this. So there is no induction of labor and cesarean section is carried out only for obstetric indications, not to reduce the COVID-19 infectivity. And at the time of delivery, direct cord clamping is not advocated. Healthcare providers should wear appropriate personal protection. And then postpartum, more guidelines recommend rooming in of the baby. You need not separate the baby, and if the mother is fine and able to breastfeed the baby. Next is syphilis. It's again a sexually transmitted disease caused by Treponema pallidum. And it again has 3 types of presentation: primary, secondary, tertiary, and congenital. We are bothered more on congenital syphilis, not the primary, secondary. We all know this placental pathology and this affects. So diagnosis will be again VDRL. False positives will be more. So we should do FTA and ABS titers should be done. And then management will be benzathine penicillin. To prevent congenital syphilis, 2.4 million units is given a single dose, and sometimes a second dose is also recommended. Congenital syphilis, this is where we are bothered. So evidence of congenital syphilis on ultrasound, we can see edema and non-immune fetal hydrops especially, then cutaneous lesions, pumped Hutchinson's teeth, saddle nose. For all these things, again, treatment will be IV, aqueous penicillin, 50,000 units should be given to the baby. The next
I think
infection.
we can wind up, madam. It's already late. Yeah.
Sorry, ma'am, we will not have
I'm
time to
sorry.
complete the rest.
Yeah.
I'll just go for
We're so
take home
sorry about
message.
it.
Ma'am. I'll just go for take home message.
Yeah.
Yes, ma'am.
Infections is too much. So I
And
just want
in
to
fact, ma'am, we are
summarize.
expected to keep up the time much more than our regular meetings, ma'am.
Okay, ma'am.
So sorry about it.
So I just want to summarize my whole thing. So certain congenital infections like rubella, HM, cytomegalovirus, HIV, toxoplasmosis, all these they are more dangerous and cause teratogenicity in the first trimester, where we have to catch up the early and prevent the congenital anomalies. Certain infections like postnatal infection, gonorrhea, chlamydia, and remaining streptococcal infection through umbilical, these causes meningitis, septicemia in the postnatal period, which we should prevent those. Then perinatal infections, again, during the labor, Neisseria, chlamydia, HSV, E. coli. For this, strict asepsis and IV antibiotics prophylactic will prevent those infections. I just want to close my discussion telling a take-home messages. Depends upon the gestational age and this infectivity and the type of organism infected, we have to detect early using PCR serological test or ultrasound and prevent further risk or congenital anomalies to the baby. Thank you so much, ma'am.
Thank you, Dr. Nazia. It was actually an elaborate talk. We too are actually very eager to hear to all your topics, but for want of time, we are concluding it. I mean, questions to be asked. Actually, we have a lot of questions, but then just like you were mentioning about the herpes simplex virus.
Yes,
so deciding upon the mode of delivery, how do we go about it? Is it universally cesarean or we can allow for vaginal as well?
It's not
In
like
case of
universal.
active
Yes,
infection.
ma'am. If a patient has got infection within 1 week of delivery and acyclovir has not started, she came to us. First cesarean to be taken for obstetric indications, ma'am. But if there is a time to give acyclovir for at least 24 hours before the delivery, then vaginal delivery can be allowed, minimizing vaginal examination and rupture of membranes to be avoided and giving prophylaxis to newborn, I feel.
So actually speaking, the mode of delivery should be decided upon depending upon whether it is a primary infection or a secondary infection. Okay. So even in secondary infection, even if there is any active lesion, because as the woman has already antibodies, so that might not affect the baby. Okay. So it all depends. We need to find out whether it is a primary or a secondary. Okay. So there are a lot of questions, by want of time, we are concluding it. But anyway, it was a good presentation. Thank you so much.
I really apologize for late, ma'am. Next time I will be.
Yeah, it's okay. Thank you.
Sorry, ma'am.
Thank you.
Thank you. Thank you, Dr. Nazia, and thank you, Shanti ma'am, and that
Kartika madam.
well, that was very good presentation, both of them. But actually, because of want of time, as you said, we had to wind it up. It was short notice, but they both did very well. Thank you so much. So thank you, Shanti ma'am.
Thank
Move
you.
on to the next presentation. We invite Dr. Sumati ma'am to chair the next session on ectopic pregnancy. Madam Sumati ma'am is the Medical Director, Darshan Fertility and Women's Medical Center, Chennai. And she's a Senior Consultant, High Care Hospitals and Joint Treasurer of FOGSI, South Zone Coordinator, Public Awareness Committee, FOGSI. And she's a Master Trainer, DIRA, and to Violence Against Women. She's a past co-chairman of this Wing IMA, Council member, and National and International Conference, traveler, and a blog. Wonderful person, more than everything. Welcome, Sumati ma'am.
Hi, good evening, everybody. And
hello, ma'am.
I am so glad that I'm able to join you today. And thank you for the invite. I now request Dr. Sujata Adagesan to give her talk on ectopic pregnancy, a much needed talk. So many lives can be saved and lives may be lost if we don't make the right decision in this particular illness and sudden tragedy. She is a professor in obstetrics and gynecology in Tirunelveli Medical College Hospital, Tirunelveli. She is a FOGSI Tirunelveli branch secretary for the past 5 years. She has organized many CMEs in Tirunelveli Medical College and the FOGSI Society. She has conducted workshops for OB-GYN, and she has published 6 papers in international journals, won the Best Paper Award, and she is a national faculty in ASUOG twice before. She is a former president of the OJ Society, Tirunelveli. Dr. Sujata Adagesan, I invite you for the talk.
Thank you, madam, for your wonderful words. Madam, am I audible, Dr. Radhika?
Yes, ma'am, you are audible.
Yes, ma'am.
Yes, ma'am, I'm sharing the slides, ma'am.
Yeah. Please share my slides. I'd like to thank Sampath Kumari madam, Radhika Gauri, the entire TNFOG team, Sumati madam for her nice words. And I like to be short and crisp. Madam, you can start. So everybody knows ectopic is some implantation of the fertilized ovum, which is outside the uterine cavity or some abnormal areas within the uterine cavity. Next. So the common is outside the uterine cavity. So 95% is a tubal pregnancy, which occurs of this 70% occurs, the common site is ampulla, 12% occurs in the isthmus, and 11% occurs in the infundibulum, and 2% is in the interstitial, or also it can interchangeably called cornua. Cornua comes in the uterine site also, because sometimes a uterus with a rudimentary horn, we also call it as a cornual pregnancies. And outside and extra uterine, other uncommon areas are ovarian and abdominal pregnancies. In uterine, you can have some abnormal sites like cervical, angular, cornual, and the cesarean scar. So these are now seen on an increasing trend because of the various factors which we'll be discussing later. And this abdominal pregnancy also, it may be primary or secondary. Next. So we have the various implantation sites. The common is the tubal, and that too, which is common in the ampulla. Next will be the isthmus, and then infundibulum, and then will be the interstitial. So if you see the incidence of ectopic pregnancy is roughly 1%, that is 1 in 100 pregnant women will be affected. But it varies. It can be 1 in 25 up to 1 in 250. That depends upon the various other factors. Sometimes late marriages, childbearing, they have an incidence of more than 2%. Artificial reproductive technique, the incidence is increased. One ectopic, the recurrence is 15%. If she had 2 ectopic, many we have seen the same side ectopic occurring again, and it is 25%, it is increased. Next. So the etiology, we see that anything which interferes with the movement of the fertilized ovum within the tube, then it can cause a ectopic implantation or some other site. So this fallopian tube ampullary end is the favorable site for the fertilization to occur. From there, it has to travel and come to the uterine cavity and get settled. So when this factor is interfered, it may cause ectopic pregnancy. Next. So it may be some factor like the tubal hypoplasia, because many, more than 50% cases of ectopic, there is no predisposing factors. So that you must have it in mind. So there could be some other causes which we are not able to identify. Tubal hypoplasia, tortuosity, some diverticula, accessory ostia, some stenosis, polyps. Also, all this can occur. Next. And also acquired causes are more common. So pelvic inflammatory disease, this 1 attack, 2 attack, 3 attacks. So it almost increases up to 10% the incidence of ectopic in pregnancy. So now they have seen that chlamydia is the most common cause, causing an infertility, PID, and also the ectopic. And if you take the contraceptive failure, which may be a temporary method or permanent method, like IUCDs or some sterilization techniques. When failure occurs after a contraception, which may be a temporary or permanent, the incidence of ectopic is high rather than an intrauterine pregnancy. So only they have seen. So after a failure, if a pregnancy occurs, then the incidence of ectopic is more, particularly if a NOR plant. And the failure cases, if you see, 30% will be ectopic. If you see the tubal sterilization, after a bipolar cauterization, if a ectopic pregnancy occurs, 65% can end in an ectopic. So similarly, interval self-injectomy, postpartum self-injectomy. So all this, if a failure occurs, the incidence of ectopic will be very high. Next. So similarly, some surgeries done on the tubes, like recanalization surgeries, tubal reconstructive surgeries, and other procedures which are carried out, like reproductive techniques, ovulation induction, IVF, and embryo transfer. So all this increases ectopic pregnancy, not only ectopic, heterotopic pregnancy also. So we will land in a dilemma. And previous ectopic, definitely it will increase the incidence of ectopic. Next. So we also have some risk factors. Always we should be suspicious when a woman becomes pregnant. And also there are some risk factors when it is, these can predispose to ectopic. So age is more, and previously some induced abortions, pelvic surgeries, cigarette smoking, which can impair the motility of the cilia, diethyl silvosterol exposure in utero, then infertility, all these infections, pelvic infections landing in SIN, genital tuberculosis, fibroids, adenomyosis, all this can favor. Next. And we have an iffy hypothesis, similarly for endometriosis, where there is a theory of reflux of menstrual flow. Similarly, there can be a reflux of the fertilized ovum, which is thrown back into the tube. So that can lead to, so these are all theories they give. Or sometimes there may be the zona pellucida, which is prematurely degenerating, or the decidual reaction is more, or there may be a tubal endometriosis, or this pathophysiology may be there underlying, which is predisposing on to this. Next. So we know that, next slide, please. So ectopic pregnancy, we have an acute or a chronic ectopic pregnancy also. So the classic triad of an ectopic pregnancy is pain, amenorrhea, bleeding. So this will be a classic triad which occurs in a various permutations and combinations. So if she is a ruptured ectopic, we will have a different picture. Impending rupture or unruptured, or there's a pregnancy of unknown location, there will be a different picture. If it is a chronic ectopic, the picture will be entirely different. So you should have a high degree of suspicion. So anybody, a woman coming, reproductive age group, coming with an abnormal bleeding, don't brand as an AUB. So you should have a high degree of suspicion. So many cases we have detected. They will come as an AUB. And if you see, the UPT will be positive, and it will be either a ruptured or an unruptured or a chronic ectopic. So always you should have a high degree of suspicion. So acute, the triad is pain, which is the commonest presenting feature, 95% will have, and the severity varies. And there will be amenorrhea present in 60 to 80%, and a vaginal bleeding will be present. And 10% will have fainting attacks also due to the stretching, the pain, everything. And pregnancy symptoms will also be present. Next. So you have ruptured ectopic, it will be very easy to diagnose. The patient will have an anemia, pallor, and hypotension, tachycardia, hypovolemia, all this will be present. And some lower abdomen distension will be there, some tenderness will be there. And if you do a vaginal examination, there will be a movement of cervix will be painful. So it's a classical, it's very easy to diagnose. If you put an ultrasonogram, there will be free fluid and UPT will be positive, so very easy to diagnose. An unruptured ectopic, and it will have symptoms of early pregnancy. She will have amenorrhea on variable degree of bleeding. There may be spotting or amenorrhea alone, and all pregnancy symptoms can be there. Nausea, vomiting will be there. If you see that bluish vagina will be present, and there will be a pelvic pain will also be present. Next. So if the patient is in ruptured, it's very easy to diagnose, which I have already described. Next. Next slide, please. Next slide. Next slide, please. So we have ruptured and unruptured, and another condition is a chronic ectopic. This is so it can be also have should have a high clinical suspicion when any women of reproductive age group enters. Kindly don't hesitate to do an urine pregnancy test. So high degree of suspicion should be present. So they usually will have a previous attack of acute pain, and from that she would have recurred, and then she will be continuing amenorrhea or various bleeding on and off. She'll be having bleeding, and it will be the small minimal collection. It will be converted into a mass, and it will cause symptoms like dysuria, retention, or rectal tenesmus. All this, the patient will be pale, and she'll definitely will have some sick look, not a normal look, and very degree of pallor will be present, and some raised temperature can be there due to the blood collection, and the features of shock will be absent. Next. So the diagnosis of next. So already we have discussed about the symptoms. So what bedside test we do? That's a urine pregnancy test everybody does. So urine pregnancy test, you should know that it has some hitches also. So you are doing an urine pregnancy test. We have a highly sensitive test also, and a routine test we are doing. So this highly sensitive, it can detect even 10 to 15 MIU per ml. And this routine, what we do, can detect 20 to 25 MIU per ml. So this, but this routine test has a sensitivity is a little more. This highly sensitive can give a false negative also. So all this you have to have, and the principle is the same. And sometimes you can have a hook effect. That is very high level of HCG will have a negative. So whenever urine test is positive, and you can have false positive in some cases and false negative in some cases. So false positive can occur when there is a bleeding, or she has completely aborted and she has come. That UPT will be positive. She is on ART treatment. She will be taking HCG injections. That may give a positive effect. And so similar, some conditions, urinary infections, blood in the urine. So such cases can give a positive result. So whenever urine test is positive, you have to have all these things in your mind also. And when these tests, chaldosynthesis, this was done before. Then nowadays we don't do because of all the gadgets available. And if it's a bedside test, if it's a ruptured ectopic, it may be positive. We used to do it in our PG days and early days. And when ruptured ectopic, it's very significant because we don't have scan at that time, and it's very easy to do. And typically they'll tell you aspirate the blood and see in front of the light, and you can see that it will not clot, and within that you can see the micro clots will be seen. That's very typical. So if you take a frank blood and it clots, you have pricked some vessel. So these things we used to see, and it was very useful. You can see the typical fluid blood with the micro clots, and it's a diagnostic, and we used to do this routinely, but nowadays we don't do this as a routine. Next. And you do go for a scan also. Next slide, please. So ultrasonogram, you know, when there is an ectopic, when you suspect, the uterine cavity will be empty, and you will see some adnexal mass, and adnexal mass you will have the slide before. You go to the previous slide. Yes, next please. Next. Okay, in ultrasonogram, you will have the typical empty uterus and an adnexal gestational sac surrounded by a hyperechoic ring. And if you put a Doppler, you can have the ring of fire appearance. Sometimes you can see only a hyperechoic mass. There's no evidence of sac or embryo. And sometimes if it is, you can see the cardiac activity also. So majority, 85% will cases, you can have a corpus luteum on that ipsilateral ovary also. So these findings you can have. Previous slide, please. So you are doing an ultrasonogram and we have a discriminatory level. So you are doing an ultrasonogram, no sac is seen and the beta HCG level is 1500 IU. Then more likely for an ectopic pregnancy. So for trans-abdominal ultrasonogram, if you see a beta HCG level 5000 and there is no sac, then you too, some say it is a 3500 to 5000, but the discriminatory zone can vary according to the institutions. That is one of the guidelines which says. And then you have to suspect an ectopic. And similarly, you should know the formula to calculate the rise of beta or fall of beta HCG. That is 100 into current HCG by previous HCG minus 1. So this formula you should use so that you can calculate the rise after 48 hours. So this you should know and you should have it in your labor ward or something. Next slide, please. So now comes our important investigation, which is for an unruptured ectopic or pregnancy of unknown location, where you go for a beta HCG. So this beta HCG, single beta HCG is of no use. Only a serial beta HCG will help to conclude. So if the beta HCG is less than 500, the doubling time will help you. And the rise of HCG after 48 hours, already I have given the formula. You have to calculate the rise. It should be more than 63%. Then it indicates a intrauterine pregnancy, if going to develop or it will appear. If the rise is less than 63% in 48 hours, it indicates either an ectopic pregnancy or a non-viable intrauterine pregnancy. So whenever you do an beta HCG, repeat after 48 hours. If the rise is less than 63%, you have to know whether it is a failing intrauterine pregnancy or ectopic pregnancy. So you have to go for other values also. So sometimes when the some patients, they come with the beta HCG values. So if you say chemical pregnancy, to say chemical pregnancies, they should have 2 beta HCG values more than 10. And around 15%, you should know that 15% of a normal viable intrauterine pregnancy will have less than 63% rise after 48 hours. And 13% of the ectopic pregnancies will have a normal doubling after 48 hours. So there is, all will have some changes also. So we cannot have a hard and fast rule, but you should be very clear that these things can happen also. Next. So always when you do a serum beta HCG, you have to take, you are going for 2 serum beta HCG levels have taken. Still you are not concluding. You get a help of a senior healthcare professional. After 3 serum beta HCG levels, further levels, you have to you take a help of some consultant also. So always you have some help. The discriminatory level for beta HCG for which intrauterine pregnancy should appear by a TVS is 1500. Next. So the beta HCG 15%, again I am stressing 15% normal intrauterine pregnancies will have less than 63% rise. 13% of ectopic pregnancies will have a normal doubling time. So after 2 serial beta HCG measurements also, you can have some hitches in diagnosis. Next. So these are other theoretical investigations which are available in all standard books also.
Sujata ma'am. Sujata ma'am.
I think her line got disconnected. Can somebody call her? How many more slides to go?
Sorry, I lost my link.
Oh, yeah.
Am I audible?
Yeah. Yes, ma'am. Yes, ma'am. You're audible.
Okay.
Yes, ma'am.
Am I
Continue.
audible?
You're audible, ma'am. Please continue.
Okay. Sorry, I lost my link. So these serum progesterone and these are all for theoretical. More than 25, it's a normal pregnancy, and less than 5, it is a non-viable. So this 5 to 15, you have to suspect some ectopic. Yes, next slide, please. And diagnostic laparoscopy, it is the gold standard, and this can be done when the patient is hemodynamically stable. Whenever you have some confusion, we are not able to conclude with your serial beta HCG and all other investigations, you can go for a diagnostic laparoscopy. Next. And dilatation and curettage. This also has some role whenever there is you don't have some conclusions obtained. And then when there is a very thick endometrium and the beta HCG is rising and you are not able to locate the pregnancy. So we can have this also. When we see a decidua without chorionic villi, it is suggestive of ectopic. It is only suggestive and not a diagnostic. Next. So other hormonal tests which are in literature, we have a placenta protein, PP14 and PAPA. These are all decreased. And CA125 and alpha-fetoprotein, these things are elevated in ectopic pregnancies, which can give some additional information. So whatever we discussed, which is given, is as a nutshell. Next. So we have some differential diagnosis also for any abdomen, usually a ruptured corpus luteum that can have mimic and it will present as a ruptured ectopic, and all other medical or some surgical emergencies can be coexisting. So which we may confuse you also. Next. So ectopic pregnancy, we are coming to the management. This is an outline and we'll discuss in short. Next. So you have expectant management, medical management, and the surgical management. So expectant management, just you are going to observe. So you have an identification criteria. The tubal, it is only for tubal pregnancies, hemodynamically stable. The hemoperitoneum should be low, that is less than 50 ml. And the adnexal masses should be very small. And the initial beta HCG should be less than 1000. And you can just observe, and you have to do a serial beta HCG. Very close monitoring is done, and there should be a slow and steady fall in the beta HCG. Then you can go for an expected management alone. The success rate is up to 60%. Next. You can do the beta HCG and repeat the TVS when you follow up in the expectant management. Next, please. So medical management. So you go for medical management. It should be an unruptured, less than 3.5 centimeter sac without cardiac activity, and serum beta HCG less than 5,000 is ideal. 5,000 to 10,000, that depends upon the individual cases. That is, and also persistent ectopic after a surgery, conservative surgery, you can go for a medical management. So patient selection, again, the low beta HCG, size is less, absent cardiac activity is the ideal selection. And you can go for some other indications, which we'll deal later. So you have to calculate the methotrexate dose exactly. So the body surface area in meter square should be calculated. That is the entire square root of 18 centimeter into 18 kg divided by 3,600. The whole square meter of the square root of this gives the BSA. So without calculating BSA, don't go for the dosage. So it is 50 milligram per BSA. Either you can select a single dose or a multiple dose. So single dose you give on day 1, repeat the beta HCG on 4 and 7. There should be a 15% fall in the beta HCG between the days 4 and 7. Sometimes there will be initial rise will be there. But between the 4th and 7th day, there will be a 15% fall should be there. Already we discussed the formula, how to calculate the rise or fall of beta HCG, the formula. So you have to calculate the beta HCG rise or fall. And if it is declined by more than 15%, you can just wait and watch till it comes negative, and you have to watch. Weekly, you have to do the beta HCG, and it will till it becomes negative. And next will be the multi-dose regimen. Previous slide. So you can select the multi-dose regimen also, depending upon the size, beta HCG level, size of the mass, everything. So the same, you calculate the dose, you give 1, 3, 5, 7, you give the doses, alternating with the leucorin on 2, 4, 6, 8. Here you have to repeat the beta HCG every 48 hours. And similarly, until the decline comes to 15%, then you can change it into weekly. And these methods, single method or a multi-dose method, it needs a lengthy follow-up, very good understanding by the patient so that they will cooperate. Next. Next, please. So methotrexate therapy, single dose, which we have discussed, and the 15% should be, there should be a fall, and more than 15% fall should be there between the 4th and 7th day. And if the pediatric activity is present on day 7, you give a repeat methotrexate and consider this as a new day 1 and begin the monitoring. So if it is not decreasing, fetal cardiac activity persists, then even after 3 doses, consider the next management. Next. Next. So if you see the success rate, it is around 93% if the size is less than 3.5. And if it is more than 3.5 centimeter, it is around 87 to 90%. Next. And if you see the failure rates, according to the beta HCG value, if it is less than 1,000, the failure rate is only 1.5. It is 1,000 to 2,000, 3.8%. If it is 2,000 to 5,000, it is around 5.6%. If it is 5,000 to 10,000, the failure rate is 14.3%. Next. So contraindications, there is some sensitivity, tubal rupture is there, size is more, when there is a coexisting intrauterine pregnancy, breastfeeding, ulcer or pulmonary diseases, immunodeficiency or hematological hepatic renal dysfunction, she is on anticoagulants, alcoholism, and not able to come for a lengthy follow-up. Next. These things. So 7% of the women still has a risk of tubal rupture. The risk of rupture is there until the beta HCG is negative, that is less than 20. So you should have this clearly in mind. And the literature has reported that the rupture has occurred 34 days after the starting the medical therapy, that is medical management. So you have to be very careful, bear all this in mind before and when you follow up the patient. This rupture can occur even after many days. Till it becomes negative, you still have that complication can occur. So you can be avoided. This has to be avoided some in NSAIDs or aspirin and alcohol exposures, taking and then exposure to sunlight, because this will cause some dermatitis, etc. So heavy lifting, you ask her to avoid intercourse or some deep pelvic examination. This should be avoided. And mouthwash with chlorhexidine. These things should be avoided while she is on methotrexate management. Next. Next, please. So the management, when it goes, this fails, or sometimes you can go for a surgical management. So surgical management, already a ruptured one, or she is hemodynamically unstable. And when there is a cervical excitation causes a pain, and abnormal mu score is there, falling level of hemoglobin, she is becoming pale, and the conservative or a medical management fails, all this you can go for a surgical management. So it may be a self-injectomy or self-injotomy or a self-injostomy. So when one tube is normal, you can go for a self-injectomy. That's what the literature says, standard books. So one tube, when the other tube is also affected and dearranged, you go for self-injostomy or an otomy. So self-injostomy will be ideal. To make an incision, you suck out everything and you give a good wash and you remove all the products and leave it as such without suturing. So when these conservative surgeries, they have given a very good results compared to the medical management. Multicentric trials have proved that. Next. So various conservative measures are there. We can go for a resection and knee anastomosis, and also milking the film of the ectopic material when it is in the ampullary end, that is the distal or the infundibular pregnancy. But there is all chances of risk of persistent ectopic. So always it has to be followed up with a beta HCG. If needed, you go for the medical supplement also. Next. So some contraindications, relative contraindications for surgery. It may be a coronal pregnancy or a cervical pregnancy or high risk for, they have multiple surgeries undergone. You think there is a high risk for intra-abdominal adhesions. So high anesthetic risk. So such cases you can closely monitor, and even for cases with high beta HCG and larger size, you can try with a very vigilant monitoring. Next. So surgically administered medical treatment. So you can administer some material, that is methotrexate or KCl directly into the sac. So you are administrating the material whether through the laparoscopy, or suppose it is a cervical pregnancy or a scar pregnancy, you can administer through the ultrasound guided also. So laparoscope or ultrasound guided, either transabdominally or transvaginally, you can administer. That is called as the surgically administered medical treatment. This can be utilized for that is cervical scar pregnancies, corneal pregnancies, where your medical treatment will have a high failure rate. And surgical treatment will also have torrential bleeding and may end in a hysterectomy. Next. So these trophoblastic substances, trophotoxic, are used. Next. So we will have just a few words about these pregnancies. So interstitial pregnancies, and this occurs in this interstitial portion of the fallopian tube. So the main disadvantage with this is that it can grow for a longer time, even up to 16 weeks, because of the myometrial expansion. And once it ruptures also, the hemorrhage is very heavy, because of the two, it gets supplies from both uterine arteries and the ovarian artery. So it has a very high torrential bleeding. And if you see that it is lateral to the round ligament. So you have to differentiate it from the angular pregnancy. So angular pregnancy, it occurs medial to the round ligament. This one occurs lateral to the round ligament. It can go for a longer time. There is the maximum time, even up to 16 weeks. And if you see the ultrasonogram, gestation sac is seen separate from the endometrium, and the distance of more than 1 centimeter from the lateral edge of the uterine cavity. And you can have an interstitial line sign. That is, an echogenic line is seen from the gestational sac to the endometrial cavity. So this classically, this interstitial line sign, it will help to diagnose, differentiate it from an angular in an early period itself. Next. So this interstitial pregnancy, sometimes when it occurs, interchangeably, it is called corneal pregnancy also. And the rudimentary horn, the pregnancy also, we call it as a corneal pregnancy. So this corneal pregnancy, can grow for a longer time. Torrential bleeding will be there. And so the management should be, the diagnosis and the management should be very quick. So the medical management, you can go for systemic methotrexate, direct injection into the sac also, or you can go for a corneal resection or cornostomy with sucking all the contents, followed by a medical management. So different types of managements are there. Histoscopic resection under a laparoscopic or ultrasound guidance. So different management that depends on what period of gestation you are diagnosing and what is the size of the tumor and whether it will respond to your management medically. So all this will decide. Suppose it is more than 9 weeks, so the medical management will definitely fail. So then you have to go for a surgical management. So that depends on all this, and then you have to decide. Size is more than 9 weeks, more than 10,000 IU. So definitely your medical management is going to fail. So next is your angular pregnancy, that is medial to the round ligament, and the implantation, it will have an irregular enlargement of the uterus, and 50 to 55% of the angular pregnancy can grow and up to term. So again, your management is either you can go for a conservative management, or as it grows, you assess and you have to decide, because all these pregnancies, interstitial, angular, all these pregnancies incidence are very low. So as per literature, the management, definitive management is only individualized. So they have not given a definitive protocol as for a tubal pregnancy. So the affected carnua with the pregnancy is removed, or it may end in a hysterectomy also, or hysteroscopically you have to try. So different managements are there. That depends again on the beta HCG level, size of the gestation sac, and your availability, what modalities are available with you. Next. So cesarean scar, which we see nowadays, very common. So they usually come with a threatened abortion or inevitable abortion, and we can diagnose easily. An ultrasound, you can have 4 findings. There is an empty uterine cavity, gestation sac is attached in the lower part, that is in the scar area, and there will be empty endocervical canal. The mass is in the anterior part of the uterine isthmus, the myometrium between the sac and the bladder is absent or thin. So these classical features will be present. Next. So cesarean scar pregnancy, you have to, the risk factors, the previous abortions or cesarean, Asherman's, so IVF pregnancy. So these all can induce, and the incidence is very less only. It's 1 in 18,000. It is, next to, sorry, the slide before, previous slide, previous. So when you, previous slide, previous slide. So cesarean scar ectopic, again, the management will be, surgical will be ideal, because the scarred area, your the methotrexate penetration, everything, it usually ends in a failure, even for a small pregnancy. So better you can go for a intra-sac methotrexate, or you can give a KCL to collapse the fetus, and you can go for either a DNC also, or you can excise the scar with the suturing. So all this can be tried. You can use a diluted vasopressin during surgery before the excision. So these things are available for us. We personally have a lot of cases of cesarean scar ectopic pregnancies nowadays, and we give methotrexate, and then usually it doesn't lose the, it continues to grow only. And then under a scan guided with all the consent, we go for a manual vacuum aspiration, and then Foley, we keep a Foley bulb to arrest the bleeding. Sometimes it's not possible, and it has ended in laparotomy, and it has sometimes, very rarely, it has ended in hysterectomy also. Nowadays we get a lot of, but many cases personally we have handled, and it has come through a through DNC itself. We have removed everything. That is, we do a surgical management, but we give everything ready. Blood will be ready for a laparotomy, and the anesthesia, everything we prepare as for a major surgery. But many times we have ended successfully in emptying the uterus. And the one thing we have to advise the patient is that, again, she can have a cesarean scar pregnancy, and if at all it occurs, she can end in a placenta previa accreta also. So next. So in cervical pregnancy, the implantation occurs, it is below the level of the internal loss, and the incidence is also less. Next. So here you have, when you send the specimen, these are the criteria they say. Rubin's criteria. Cervical glands will be present opposite to the placenta, placental attachment to the cervix below the level of uterine vessels, and fetal element is absent from the uterus. So it will not be present within the uterus. So these criteria will be seen. Next. So cervical pregnancy, usually it presents with the bleeding. So you have to go for some management, either direct injection into the sac along with the systemic, or if it is more, size is more, and the beta HCG is high, then you can go for an intracardiac KCL under the ultrasound guidance, and then you can go for the management. To reduce the bleeding, you can apply some circlage at the level of the internal os, or you can use a intracervical vasopressin, or vaginal placement of hemostatic sutures at 3 o'clock or 9 o'clock position. Following emptying, you can keep a Foley tamponade. So these methods will help you to evacuate it without ending in a radical surgery. Next. And ovarian ectopic, it's very, very rare. And the risk factor is an intrauterine contraceptive device and endometriosis. So everybody knows of this famous criteria, Spiegelberg's criteria. And the clinical features are same as pregnancy, and usually it ruptures yearly. And the Spiegelberg's criteria is the same, say tube will be intact and separate from the sac, and the sac occupies within the ovary. It is connected to the ovary by the ovarian ligament, and ovarian tissue will be found on its wall in histopathological study. So surgical management will be the first day of management for an ovarian pregnancy. Next. So abdominal pregnancy, again, it is one of the rarest. I have seen 3 cases of abdominal pregnancy. 2 are secondary abdominal pregnancy. Usually it's a patient comes, some pain will be there, some bleeding will be there. If you do an ultrasonogram, the FH fetus will be live, and it's of 16 weeks or 18 weeks. And you'll have, but the patient will have some discomfort. She will not be healthy. She'll have some tachycardia, some minimal fluid, and some tenderness will be different. So there will be painful movement will be there. So it will be in any time it will rupture and she will collapse. So we have seen secondary abdominal pregnancies, and laparotomy is the first. Whenever you diagnose abdominal, it may be a primary or secondary. A surgical management will be the first day of management. So it is because MMR is 7 to 8 times higher than the tubal ectopic, 90 times than the intrauterine pregnancy. So always there will be some abdominal symptoms, spotting, and you can see a live fetus. It will be moving. So primary abdominal pregnancy, again, it's also very difficult to diagnose. High degree of suspicion should be there, and there will be no liquor, and the baby will have oligohydramnias, and it will not grow properly. So all this will be, you have to do an MRI, you have to locate and locate the placenta, map the placenta before going, and the entire setup should be there to tackle when you go for an management, because it may be placenta may not come out, there may be torrential bleeding, and it may be attached to an intestine. If it is to an momentum, it will be easy, but if it is into an intestine, it will be very difficult. The bleeding may be very heavy. So everything you should be ready to tackle when you go for a laparotomy. Next. So here the tubes and ovaries will be normal. There will be no fistula if it is a primary, and it is related to the peritoneal surface. And if it's secondary, means it has escaped through some rent. It may be intraperitoneal or extraperitoneal into the broad ligament. Next. So heterotopic pregnancy, it's also very rare, 1 in 30,000. Along with the ART, the incidence is increased after ovulation and ART techniques. So there will be a rising titer after a rising titer will be seen, and more than one corpus luteum at laparotomy. So there will be seen. So the management, it depends on the site, and the ectopic will be removed. So whenever there is a heterotopic pregnancy, you have to remove the ectopic pregnancy. We cannot use a systemic. When she wants the intrauterine pregnancy, you cannot use systemic methotrexate. So you have to go for a intrasac administration. You cannot go for a systemic or laparoscopy and remove the excise the ectopic. So that will be the ideal, and you have to give an anti-D also. Suppose she is not willing to continue the pregnancy, it occurs de novo, then the management can be, you can remove the DNC and go for a medical management for the ectopic. Next. So pregnancy of unknown location, again, it is beta HCG is measured, it is rising, and we are not able to locate the site of pregnancy. So if the rise is more than 63%, pregnancy is going to develop intrauterine. So you go for a TVS between 7 and 14 days. With the decreasing in beta HCG, the fall in beta HCG is more than 50% after 48 hours, then it is likely the pregnancy is healthy, it is not going to continue. So between this 50 and 63, again, it is more likely the ectopic can be there. So you have to get explain everything to the patient, and you have to have a serial follow-up, so that sometimes she is completely aborted, so coming with a positive, or she has given some form of treatment, or sometimes very rarely a beta HCG secreting tumors, HCG tumors may be there. Even elderly women nearing menopause, coming with this high beta HCG, there may be intracranial tumor secreting this HCG. So all these possibilities are there. So which you should, then also some other remote areas of pregnancies can be there, like a splenic area or liver. So these things all should be, you have to have in mind. When you are not able to make out, better you are not detecting an intrauterine pregnancy also. Beta HCG rise is there. You are doing all these things, and then better to go for start a medical management. Next. So other rare types, you can have these are the sites you can have. Next. And you can have double ectopic pregnancy. That is on both tubes. Multiple pregnancy in an ectopic pregnancy. So these things are now coming more. So we have to have everything in your mind before you think that it is only ectopic or only intrauterine or heterotopic, or the pregnancy is hidden somewhere. So you have all this picture in mind, and before you go for the management. So always be aware that even at level of 20, it can rupture. So unless it becomes negative, you have to have a very close follow-up. Next. So thank you, the entire TNFOG for the wonderful opportunity.
Thank you very much, ma'am, for the elaborate lecture. You covered almost everything. The first thing what I liked in your thing was highlighting the high degree of suspicion what we should have whenever there is a woman who is coming to us in the reproductive age group, in particular presenting with AUB and pain. Always think of pregnancy related events and ectopic pregnancy. That was point number one. The second point was what I would like to reiterate is we as gynecologists must have ultrasound doing capacity, and our clinics must have ultrasound so that we pick up ectopics at the earliest and not a delay in referring from one place to another. And we must always have a robust help and a reliable help which is available whenever we have a doubt in an ultrasound, and we must have an assistance for a laparoscopy unit or an emergency tackling unit to save lives. One big point what I found in your topic was, ma'am, you mentioned about bipolar cauterization and unipolar cauterization when used as sterilization methods, resulting in 20 to 65% of ectopic pregnancy rates or ectotopic.
No, it's just like among the failure, it is more.
Yeah,
so
failures.
When the failure is
yeah,
only
whenever
1%.
the failures,
Failure
the
is less
thing
than
is,
1%.
Yeah, no. I'm talking about whenever the ectopic pregnancy is occurring, it is of that high nature in whenever it is used that technique, right? That is what you had reiterated.
That is means that the bipolar, when you are using bipolar or a Pomeroy's techniques, the Pomeroy's 0.1 to 0.5%.
Yes.
And so in this 0.1% failure occurs. Among that 0.1, it is so much, not the overall.
I get it. So this is just for the viewers. So the bipolar cauterization and unipolar cauterization, first of all, we should understand that according to the NHM guidelines and the family planning guidelines of India, we are allowed to do only rings or modified Pomeroy's techniques. The minute we mention in our case sheets as cauterization done as sterilization method, if they fail or even go into ectopic pregnancy rate, we are facing directly a medical legal case against us. So this is one point I would like to really share in this forum for people to understand, follow
right,
the
madam.
techniques. Yeah.
Yes, you are well said, madam. But and also they said that the bipolar cautery, when they use, they sometimes the whole thickness of the tube not involved. That's the reason why they have
That is why the government of India is not accepting it as a the right method for doing it. This is for the viewers to it is you either you do a modified Pomeroy's technique or you are using Fallope rings. These are the only two ways in which we need to do, so that if it is going to come, ectopic is going to come. But when you put in your case sheet as cauterization, failure, and this, the ectopic pregnancy also will be blamed on you straight away. So that is a medical legal point which needs to be noted.
Can I ask a small question, ma'am?
Yes, ma'am.
Ma'am, when we do a modified Pomeroy's technique, the suture material recommended is a chromic advert.
Yeah.
Nowadays, a lot of us, we have gone to Vicryl for cesarean. Is it okay to use it for just cost cutting, or are we supposed to use only chromic advert for it?
Always go through guidelines which are given in your NHM and in your government guidelines. Use only what is specified there. Yeah. That's all. It's very simple.
You have to use the catgut which dissolves earlier.
Exactly.
That is your basic. So that if the tubes go wide apart early and the suture material doesn't stay there for a longer time, more of adhesions, more of the tubal fistulas. That's the basic behind that.
That is the reason why we are using chromic catgut. There is
plain
catgut
was
recommended
ideal.
also.
We used to use plain catgut only before.
Yes.
That will be the ideal thing. Now only we have come to 10 chromic.
Wonderful. Thank you so much. Thank you.
Thank you, ma'am.
So now we are moving on to the panel discussion, Dr. Radhika.
Yes, ma'am.
So the panel
Thank you so much.
discussion is now going to have the moderator as Dr. Radhika Gauri and our expert is Dr. Sampath Kumari. She is going to bring about the panelists, introduce them, and discuss about early pregnancy bleeding, hyperemesis, and miscarriage. And Dr. Radhika Gauri is such a superb candidate who's been running this. And thank you so much She's a star by its own. I think everybody knows her. She actually requires actually no introduction.
No, ma'am, it's okay.
So since we're running out of time, please start
Yes.
off your
Yes, ma'am.
discussion, Radhika. Thank you.
Thank you for the kind words, ma'am.
Thank you.
Thank you so much. Ma'am, I'll move on and introduce Dr. Mohana Pramila, who is a consultant OBG fertility physician and laparoscopic surgeon.
Radhika, you continue, Radhika.
Yes, ma'am. And we have Dr. S. Gayatri, who is President Narchi Trinelveli, Secretary, Trinelveli Obsam Gynae Society, and she is a member of Sports and Wellness Wing in Trinelveli IMA. Welcome, Dr. Gayatri. I invite Dr. Subhatra Logidasan, who is a Managing Director, Logidasan's Hospital, Tiruvallur, and a consultant obstetrician and gynecologist and a fertility specialist from Tiruvallur. I welcome Dr. Uma Brinda, who is working as an assistant professor in Obs and Gynae Department, Tanjavur Medical College, and secretary of Tanjavur OG Society, a field of interest is high-risk obstetrics. I invite Dr. Ashika, who is a joint
Thank you, ma'am.
OB Society, and she has won numerous awards, and she's an alumni from JIPMER. I invite Dr. Siraj Fatima, who is was done her MBBS from Erode Medical College, Perundurai, Tamil Nadu, DGO from Madurai Medical College, and fellowship in endogynae, and DNB from
Thank you,
Kovar.
ma'am. Thank you.
I invite Dr. Mahalakshmi, who is a consultant Anirudh Hospital, Krishnagiri, a special interest is high-risk obstetrics. I invite Dr. Teresa Karpagaselvi, who is from Valley ESI Hospital. She's an obs and gynae specialist and excellent consultant.
Good evening, everyone. Thank you, ma'am.
So we'll move on to the case discussion. All are very practical cases, and it will be a mutual discussion, actually, not a single way. Okay, two-way discussion. So you can also bring in different cases because ectopic pregnancies and can present in various ways. So kindly feel free to give your inputs. So I'll share my presentation as well on desktop. Desktop. Okay, slideshow. Is it visible? Okay, let me start. So Mrs. X, who is 28 years old, married since 5 years, and she had a myomectomy at our hospital, and she became UPT positive after 2 years and came with irregular bleeding PV. So the ultrasound was normal, actually. Uterus was normal, adnexa also normal, and beta HCG was, we admitted her, and then the beta HCG was 300, and then it showed a rising trend. It went to 720 and then to 800, and then it came back to 259. So all this time the patient was in our hospital because she was very anxious, and so we couldn't do anything as well because she was married for 5 years and waiting for a successful pregnancy. So almost 2 weeks passed and then it started falling. So she was pestering us, and then she wanted to get discharged. And then we sent her in against medical advice, actually. So what happened next? So it was a pregnancy of location, desperate to go home. And the next day, she came back with severe abdominal pain to our casualty, and ultrasound was done as emergency. But the patient did not come back to us. She went to another hospital. But the ultrasound, the radiologist, luckily he called us immediately and he reported it as right tubal ectopic gestation. So then the patient was admitted again, and we called her and she came back to our hospital. And in the middle of the night, the ectopic right laparoscopic right salpingectomy was done, and there was hemoperitoneum, and luckily we could save the patient. So So that is why ectopic pregnancy, we should always suspect in all cases. So next, 45 years old, para 1 live 1 with irregular bleeding PV with 35 days of amenorrhea. So UPT is positive. So gestational sac was seen 4 to 5 weeks. So patient wanted termination of pregnancy. So how would you go about for the medical termination of pregnancy? Subhatra, Dr. Subhatra?
Yes, Radhika, can you hear me?
Yeah, we can hear you.
Okay, okay. So by in scan, if it is 4 to 5 weeks, then there must be only a gestation sac. It's very unlikely to see a yolk sac there. So without seeing a yolk sac, we cannot confirm intrauterine pregnancy. So it is always better to wait for at least 3 to 4 days. We can repeat a USG. By that time, we can, if it is a normal intrauterine pregnancy, we will definitely have to going to see a yolk sac. So only if after seeing a yolk sac, then we confirm it is a intrauterine, then we can proceed with the termination of pregnancy. We can go for an MMA medical management with mifeprostone or misoprostol. So sometimes we see only a gestational sac. It could be an pseudosac also, but in like in an ectopic pregnancy. So it's always better to wait and then do a repeat scan. Go see the yolk sac or embryonic fetal pole, and then we can go for an medical management. So, but it's better we go within a week, because if they are planning for a medical termination of pregnancy, then we don't have to delay for a longer period, 2 weeks, 3 weeks. So if it is intrauterine pregnancy, then it's going to be 5 to 7 weeks. Even if you go for a medical management, the bleeding will be more. If it is a lesser weeks of gestation, bleeding and the complication will be very less. So within a week, we would repeat the scan and confirm it.
Wonderful.
Yes,
Thank you so much.
agree with Subhatra, because once the patient, if they have decided for termination, they will insist us to give the tablet immediately.
Yes.
Even if
yes.
they say the sac is not visible, we can do it after 5 weeks. They think that the baby will grow, and they will miss the chance of termination. So they will insist us, and they will create a big anxiety. So we have to properly counsel them. Nothing will happen, and ask them to come only after seeing the sac. We have, that is intrauterine sac. Then only we have to give the medical method of termination.
Okay, wonderful. So in this case, what happened was patient was discharged home, and 1 week later, the patient came with, discharged home after medical termination. She was given Mifi and then meso. She bled and she thought she passed the sac. She passed a big clot. She thought she passed the thing, and then we sent her home. It happened a few years ago, actually. So 1 week later, the patient came with severe lower abdominal pain, and then the serum beta HCG was around 500. And when an urgent ultrasound pelvis was done, which showed a ruptured ectopic pregnancy, and immediately laparotomy was done, and patient was saved. So the main point here is because everybody is using the kit, the abortion kit, everybody is using, and nowadays they think as soon as they see the sac, they think it's all, it is an intrauterine pregnancy, and they give the medication, and many women, this is the result. Many of them can have this type of ruptured ectopics.
Good evening,
So we
ma'am.
should all be aware. Yeah.
Ma'am, Siraj here, ma'am.
Yes, Siraj. So all sacs are not just. Yeah.
Yes,
tell
ma'am.
me.
Similarly, we had a case, ma'am. 40 years, 1 year back, 40 years old, para 2 live 2, and she had 4 to 5 weeks vaccine and miso given outside, and she came with 10 days later. She came with pain and bleeding, and pain was very mild, and beta HCG was less than 1500, and no sac was seen in the ultrasound. We did an MRI, and they found to have a sac in the corneal region. And after that, we gave methotrexate as she was hemodynamically stable, but she didn't respond and the beta HCG levels didn't fall. So we took her for laparoscopy and the corneal resection was done.
Okay.
I like to
So
add one thing, Radhika. See,
Yes,
the
ma'am.
scan, the people who are doing, so we need to have a,
High
regular
degree of
doctor
suspicion.
who is a very good expert in scan. Otherwise, we have to do the scan by ourselves. So it's
Absolutely. Yes.
unlikely to see a pseudosec because the beautiful residual reaction we'll see in a proper intrauterine sac, which nobody
Yes.
can miss. That
Miss.
pseudo sac will be an irregular thing, and it will we can beautifully differentiate between a true sac
Yes.
and a pseudo sac. Or
Yes.
you should have a good friend of sonologist as a good
Radials.
friend, and
Sonologist.
you should have it because the last week I like to share one experience, and one doctor, she came to me. I did a scan and it was a single intrauterine gestation. So I sent her home. The next week she came and she said, one doctor from her hospital, they did a scan and said it is a twins, and I'm having severe vomiting. And I was so surprised because that was an 8 week size. And how could I miss one twins? Then again I did a scan, and it was a fibroid. So I asked her, how did she did the scan? It's a TVS or a transabdominal? She said it's a transabdominal, and she showed the heartbeat also in that fibroid. So that is what I am telling. See, many scan centers are there. Many doctors are doing the scan. You should have a
Yes.
good expert for it because
Expert.
see,
Not.
it is a
Yes.
decision making part. The scan is very important.
Absolutely.
So you don't
Yes.
send to anybody. So there are a lot of scan center. We do not know who is doing the scan there. So you should have a
Yes.
trustworthy person who will do a good scan, good reasonable scan. And it is
Absolutely.
better, as Subhati
Yes.
ma'am said in her talk, we have to do the scan by ourselves. Then it was a simple
Ourselves.
technology.
Yes. True.
And in
100%
your
true.
case, there can be a chance, rare, but still there can be a chance of heterotropic pregnancy also.
Heterotopic also.
Yes. See,
Yes.
sometimes when we see an intrauterine sac, we leave the scan there itself. Oh, it's intrauterine.
Yes.
Congratulations, everybody were happy. But
Absolutely.
even this, I am doing IVF, so we will
IVF. Yes.
implant some 2-3 embryos there. So always have a habit of seeing the adnexa, even if you see an intrauterine sac. There can be an
Yes.
heterotropic pregnancy also. Don't miss it.
Very good. Very valuable point. Thank you, Subhatra, and thank you, Mohana. That was wonderful. So the main reason we are dealing with this ectopic pregnancy this time is we have many cases, near miss case, as well as in one of the maternal deaths also. So that is why the main reason for this topic this month actually TNFOG. So we have to be always aware of the presentation, different presentations of ectopic pregnancy, and sometimes actually day before yesterday we had another patient similar to this, just with she had no abdominal pain, just a brownish discharge, and she started crying because she thought it was an abortion, spontaneous miscarriage. So then we again sent for a scan, and in the scan it was reported urgently. We sent, and luckily it was reported as a ectopic but unruptured. So then anyway, we were waiting. In the waiting period, she ruptured the tube ruptured. Actually, she started having pain, and immediately we took her to theater and we did a salpingectomy. So luckily, this woman already has a child, but still, these things every day nowadays, these days, it's become so common. And I think laparoscopy is also common. And thus, only if we have a huge degree of suspicion, we can save these patients. And post sterilization, we have to be even more. Uh, we have to think 90% it will be ectopic pregnancy if it is after sterilization, and we should get during getting a consent for a sterilization, we should mention that there is always a risk of ectopic. See, once the sterilization is done, the patients think, okay, we have done everything, we won't get pregnant, but that's not the case. If they get pregnant, there is high chance, 1 in 50 chance after 5 years that it could be an ectopic. Most probably it will be an ectopic as the tubes are damaged. So we should mention it clearly and give them options of long-acting, the reversible contraception like copper T, Mirena coil, if they want contraception. Because
I
ectopic
would like
is
to
always
add
there.
one point in ectopic
Yes.
pregnancy. So actually, we do medical management as Madam discussed previously. It's less than 3.5 centimeter, and the beta HCG less than
Yes.
1,000 or 5,000. But in practice, we don't see like that. Even with the beta HCG of 380, the patient will the previous day you will see there won't be any sac. We'll ask them
Yeah.
to come after 2 days. We should be very much vigilant. And she has come with a hemoperitoneum. Yesterday night also I saw a patient. She had a beta HCG of just 900. SAC is not seen anywhere. Just 48 hours prior. Then yesterday she landed up with severe hemoperitoneum, papery pale, and she was in shock almost. Then emergency laparoscopy was done and salpingectomy, and could save the patient.
Saved the life.
So that beta HCG, we should not slip by the beta HCG. We should be very much vigilant in seeing the patient, and we have to warn
Clinical
them.
signs.
If the UPT is positive, if you are not able to locate the sac, so it should have already risen and fallen. We do not know.
Fallen. It will be like a
Yes. So
miscarriage.
already it would have risen and fallen. So we may think
Fallen.
that it's only 380. So we can give her 4 days of time. If she is nearby, you ask her to see you, and we have to teach them the warning sign. If she is a far off, better you counsel them and admit in your hospital
Admit the
till
patient,
you
yes.
see the sac.
Absolutely.
Because night only they'll come in emergency.
Yes. Yes, true. It has happened actually. They discussed in the NHM also. There was one patient who came at night, and in one of the hospitals, they said, patient with abdominal pain. They said, okay, see in the morning. And when they went in the morning, the patient, unfortunately, she died. So these things are happening very commonly these days, but it is very unfortunate. We should, as you rightly said, we should correlate clinically. If they are in pain and they are going into shock tachycardia, all this has to be taken into account. And overall picture, not only the beta HCG, not only the scan, the overall picture, and we should, it's best to do a laparoscopy, and also blood should be ready. If we do not have blood in the ready blood bank nearby, it's best to send to the nearest higher center.
Good evening, ma'am. Ashika here.
Yeah, Ashika.
Ma'am, I would like to share an interesting case which I had encountered. That case was a primary spontaneous conception after 1 month of married life. She had initially tested the beta HCG was positive around 4 weeks, then did a beta HCG. Then she had periods on that day itself. She came back. Then the beta HCG was around 200. Initial was around 400. It was started falling, so she was kept on expectant management, just serial beta HCG monitoring. On ultrasound, there was nothing except for a thin eating. She was just bleeding. And second, again, she had mild pain, but we could notice 2 to 3 corpus luteal cysts. Except for that, there was no other findings on the ultrasound. But again, 1 week later, when she came, the beta HCG was started rising slightly. It was around it was 200 plus than the earlier value. Then again, we did a repeat scan, again expert ultrasound. There was suspicion of a tubal gestation. So admitted, methotrexate was given, and so it started falling on the 4th day. Then second dose was repeated, but on 5th day again she had pain. There was suspicion of rupture, so taken up for emergency laparoscopic salpingectomy. Actually, this patient had 3 corpus luteal cysts on ultrasound, so it is always wiser if even the first one, maybe 3 might have been fertilized, 2 in the tube, and 1 would have come out as an abortion. So if we have many corpus luteal cyst, I think we should search for another pregnancy, or keep her in on monitoring, even if she has bleeding, reducing beta HCG in the first visit. But subsequent visit, if there is a rise, always suspect ectopic, because this one. And when on again probing the history, why she had, because this patient had regular cycles previously, did not have any complaints with the cycles. When she was asked about the history, then both the couples were taking some kind of a herbal medicine. because there was 3 corpus luteal. Just one of the clue which the radiologist had given during ultrasound is she has got 3 corpus luteum. Always there must be 3, otherwise search for the other one. So this was the one which led us to suspect the other ectopics. So if there are more number of corpus luteum, I think it should be we should be vigilant in our monitoring.
And
Even
this
if we know.
yes, the medical method require enormous counseling and understanding of the patient. So what they will think, if we are successful in our medical management, they'll just appreciate and go. If we are not, because that 1 week will be a nightmare for us also. Whenever she says some pain, whenever the BP is falling, or whenever there's a tachycardia, we also will be in anxious. Whether it's ruptured or hemoperitoneum, we'll do the scan like that. And every time they'll see our expression and they'll think something is bad is going to. If we convert into a laparoscopy, they'll think that our management is wrong. Previously, first day itself you could have done, and why such a thing? We are spending for the hospital stay as well as for the laparoscopy like that. So the patient, the choosing of the patient and the attender is very, very important, and the counseling is very, very important in that.
Yes, ma'am. Fortunately, this patient actually, the attenders were very, like, they understood the full situation. They were very cooperative. And I took laparoscopy in the middle of the night as usual. So it was hemoperitoneum. I think the third one had rupture because the beta HCG started rising even after the second dose of methotrexate. So that is when we didn't wait.
Okay, very good. So we should always have a suspicion and manage.
Number of corpus luteum also matters.
Yes. We move on to the next case. So this one is a 24-year-old woman, gravida 2 para 1, presents to the emergency with the fever for 2 days for abdominal pain and foul smelling vaginal discharge, heavy vaginal bleeding. So what do we do next? First thing in the casualty. Ashika?
LMP for last
Yes.
menstrual period. And
1 month
whether
ago. UPT positive.
UPT positive. First, I would like to examine her general examination, check for her vitals, and then do a proper abdominal examination, and then a speculum examination. Since there is a foul smelling vaginal discharge, a swab has to be taken on the first look. And if there is heavy vaginal bleeding which requires immediate resuscitation, an IV line has to be put and she has to be on fluids. And on then the further history should be elicited regarding.
Yeah, she reports to attempting a terminate a 10-week pregnancy at home. 5 days earlier using non-medical methods. She went to nearby clinic. So she took the tablets, from the kit. We had a kit, abortion kit. So now the examination temperature is 39 degrees and she's tachycardic, her blood pressure is low, hypotensive and tender.
Septic abortion it is.
Yes.
So we need to admit this patient, start her on IV fluids, IV broad spectrum antibiotics, and do an ultrasound to see for the retained products. And in the retained products, we need to see for the vascularity as well, because we should not attempt anything immediately. After stabilization, then we need to do the subsequent management stepwise.
Okay.
Because I would like to tell one patient.
Yes,
she didn't have fever. I did the suction by myself 1 month back, and she ended up with bleeding. She gives a history of a bout of clots. So I did a scan, and it was a clot-like thing in the uterus. So what I did, I put just an IUI cannula. I thought, what is that thing there? Because she is very much stable. Okay, so I put a IUI cannula to aspirate and see whether it is a clot or something. Then suddenly there was a bout of bleeding. That just an IUI cannula. Because the previous week also she came, and that time also I could see some small retained bits. So the 10 weeks suction evacuation was done, and post procedure we did a scan. The cavity was empty. Then after 15 days, she came with small retained bits. So I gave her some conservative management, and I asked her to come again after 1 week. Then now I could see the cavity is full of fluid. Something is floating. So I want to see what is the actually what it is. So just a IUI cannula and I aspirated in the OP, and suddenly she had a gush of blood, the bleeding, and it was a fresh bleeding. So that was an AV malformation which I missed. So I immediately I packed the uterus. Now she was under me and conservatively we have managed. Now she is going for uterine artery embolization. 7 o'clock it's fixed nearby cath lab. So that is there because that time on that day I immediately I resuscitated, gave an IV fluid, antibiotic, methotrexate, took a blood sample for coagulation profile. I did a beta HCG to see whether there is a persistent trophoblastic disease or not, and it is 299 only, and it did correlate. So then I called the radiologist, and there was a highly vascular retained bits. So it is. He said it is a should be a AV malformation, and today she is going for uterine artery embolization.
Yes, ma'am.
At home itself, she had a good course of bleeding.
Ma'am, I want to add
Yes.
one more case, similar case like this. I had a 35-year-old patient. She had para 1 live 1, and she had one abortion before, and now she is conceived and came to me. And I did a scan, and 7 weeks her heart rate was there, and we have given folic acid and all. As she is 35, I have given ecosprin and all. And at 9 weeks, she's a bank employee. So she wanted to go to another place. So she wanted to check FH once again. Just she came as a routine checkup, and I saw FH was absent. So it's a missed abortion. So I gave her Mifi and Miso, and she has bled everything. Everything came out the next day scan. And after 10 days, she came and told that I'm working in bank, I want to go again. So I want to know whether all the bits have come. So, but as she requested, I did the scan. She didn't have any bleeding or like that. I did a scan, and there was like posteriorly in the endometrium, there was a 1 into 1 centimeter hyperechoic lesion was there, and it was very much vascular, very, very vascular, abnormally vascular. So I sent to a radiologist, one of my friends, and she told that it looks like an AV malformation rather than a retained product of conception. So MRI was done, and the beta HCG was falling. It was like around 200 something after 10 days of missed abortion. Then as she was not bleeding, I put her on letrozole for 10 days, 5 mg BD, and then Lupride. I have counseled her extensively. As you told, the attender and the patient was very much understanding and cooperative. And I told any bout of bleeding, you have to come to the hospital immediately. And uterine artery embolization also, I have counseled her. And counseling was given with the interventional radiologist also. And they decided to go ahead with medical management. And I put her on Lupride for 2 cycles and OCPs. And after 3 months, she has not bled in this time, only spotting she had. And after 3 months, I have done a repeat ultrasound with the same radiologist, and I have done myself, the vascularity is gone.
So can you repeat what are all the management
Medical
you
management.
did?
I
Medical
have given
management.
letrozole. Luckily, it was found before the patient has bled.
Okay, okay.
And it was not an surgical evacuation, it's just a medical termination.
Yes, yes, okay, okay.
And previously, she had only normal delivery, ma'am.
Okay, okay.
And I have started on one letrozole, 5 mg BD for 10 days. And then she didn't have any
This is to
BD.
suppress the receptors. Okay.
Yes, ma'am. And the guidelines recommend the use of Lupride injection and OCPs, ma'am. Both have given monthly injections and OCPs continuously for 2 months.
Okay.
She's doing well.
Methergine, did you?
No, I didn't. She didn't bleed, ma'am. Okay. That is very lucky. That before bleeding itself, we have got and suppressed everything.
Got her. Good.
Thank you.
Thank you, Siraj, for sharing. Thank you, Mona. So that, yes, so we have to be careful. In this case, it's a septic abortion. And septic abortions, we've seen numerous cases. In those days, it was very common when abortion services were not that frequent. We have seen little girls, actually 16-year-old girl with a uterus becoming gangrenous when I was doing DGO, and and they had to do a hysterectomy at that time. So it was septic abortions can happen, and even these days, if we don't counsel them to be careful and to come back as soon as they get abnormal discharge, these septic abortions can kill the patients. And so management, as um, Ashika said, emergency treatment, resuscitation with IV fluids, oxygen support, antibiotics, broad spectrum IV antibiotics. It's best to give them 48 hours antibiotics and settle them, and then then we can do a surgical intervention. If they are very sick, obviously we have to intervene quickly. Otherwise, if they are moderately, if manageable, then give antibiotics and within for at least 24 hours, then evacuation to remove the infected retained tissue. Then monitor the vital signs, urine output lab parameters, and if need, ICU care should be given. And here CRP is an important thing where it can clearly tell us whether it is infected or not. So and after 72 hours, this patient, the fever subsided and everything stabilized. Infection markers CRP also decreased, so she was discharged after 7 days. So what are the long-term complications? We have to counsel the patient that long-term
endometritis.
Infertility. Endometritis, infertility. Infertility.
Asherman's also can happen, and sometimes tubal block due to ascending infection. Yes, ectopic pregnancy in future. Okay. So sepsis is the main thing. In maternal mortality, sepsis is one of the causes. So we have to remember. So next is Mrs. X, 28 years, again second gravida, previous normal delivery, 10 weeks gestation, Brown is discharge PV, and gestational sac is 30 millimeter, CRL is 5 and no fetal cardiac activity. So we all know it is a miscarriage.
Miscarriage.
Good. So this is a common scenario, but how do we go about it? First thing is we should explain to the patient clearly and her husband. Then what do we do then? The usual one, Mahalakshmi. Dr. Mahalakshmi, is she there?
Yes, ma'am. Good evening, ma'am.
Good evening. So what do we do
Yes,
if
ma'am.
we see a patient with miscarriage?
Ma'am, informed consent for the missed abortion we have to take, and we have to take all the blood investigations profile.
Yes.
And since she's 10 weeks, it's better to go for suction evacuation.
Yes. And the risks also we should explain. Usual perforation and all those risks we should explain.
Yes,
and
ma'am.
her blood group is AB negative.
Yes, ma'am. Anti-D.
Yes, anti-D is
We have to
important.
check for the spouse blood group also. We have to check for the spouse blood group. And if medical management was said, we have to explain about the success rate and all. So since she's 10 weeks, it's better to go for suction evacuation alone now.
Yes. Actually, the main reason is the spouse blood group. Actually, we shouldn't, I think we shouldn't bother really. We should only consider the woman. It may not be the, here I just want to differ, sorry. It may not be the same, person these days, partner, may be different. So we have to treat the patient as such. If she's negative, we have to go ahead and give her the anti-D. Yes. And then medical management this case was dealt outside. Medical management was done. And even for 10 weeks, they're given tablet and they've sent her home. And there, after the taking tablets, she hemorrhaged and exsanguination and she died actually. It is another case of maternal mortality. I think in the last year, one of the cases they were discussing. So we have to clearly tell the patient, and I think better to get sign also, even for medical management. If they bleed heavily, changing one pad per hour or one pad in 2 hours, they should come back to the hospital. And we should tell this to the attender also. Sometimes they will be left alone. Nowadays, they don't have attenders. They are all in separate houses. Individually, they are living with husband or partner. So better to tell them clearly that they can bleed and they need to have an attendant to a relative who can bring them to the hospital as soon as they bleed heavily. So what is heavy? Then we should tell them that it might be changing a pad for an hour or two pads or one pad in 2 hours is also heavy. So that way we should tell it clearly in their mother tongue and get it signed. to save ourselves. So this patient has come very late in shock and she actually died. So what are the risks of
Dr. Radhika.
Yes.
So missed
Sorry?
abortion, we should have clear. We have to explain clearly. Usually,
Yes,
it doesn't come with a medical abortion. It fails because
Yes,
it may
ma'am.
be chronically adherent.
Yes,
It may come, but it so you should not send them home. Better to
Yes,
keep
ma'am.
and then follow the medical management. If it doesn't or she bleeds, immediately you go for an evacuation. Don't
Suction
send her home
evacuation.
for
Yes,
a.
ma'am.
Don't send her home.
Home. Yes, ma'am. In
That should be a
hospitals,
take-home
we do
message.
admit her. Yes, ma'am. But this patient actually, I think she was managed somewhere else. But I mean, as ma'am said, it's a very good point. Best to admit her, do the coagulation profile and everything from full blood count, keep blood ready, and we have to be very vigilant in these cases. And so the counseling.
Patient who is undergoing repeated suction evacuation also, there will be a defective myometry because vigorous suction that will cause the defective myometrium. Subsequently, when they go for any termination or something, that bout of bleeding will come. And I have seen simple evacuation, we will see some fresh bout of bleeding, which is not expected in early pregnancy.
Absolutely.
They will be having some underlying endometritis. They'll bleed. Many cases are
ma'am.
coming like that. You need to put an Foley to stop that even after evacuation.
Okay, ma'am. Police after evacuation. Okay, ma'am. It's an important point. So we have to explain clearly what are the risks of medical management, and there is a possibility to go to theater, suction evacuation may be needed. All this has to be explained in the first visit itself. And then what is the counseling to be given? We have to tell them that it is not. Sometimes they may feel very psychologically upset that they are it is aborted because of them. So we should tell them it is not due to any of the partner. So those counseling also we should, and clearly we should tell about the management. And as madam said, best to admit them and then do all the investigations and try the medical, give the tablets. If they don't expel, take them to theater and do a clear suction and give them the anti-D also. And then we have to clearly counsel them not to get pregnant up to 6 weeks or up to the next proper periods. That is also very important because there is also risk of infection due to repeated sexual intercourse. So that also needs to be made clear. So if the patient comes in shock, so what do we do? What are the symptoms? We all know this: excessive vaginal bleeding and lower abdominal pain or cramping, dizziness, lightheadedness, weakness, fatigue, palpitations, soaking more than 2 parts per hour for 2 consecutive hours. We should. So progressive tachycardia, they might come with tachypnea, narrow pulse pressure, pallor, delayed capillary refill. So late signs we all know: hypotension, altered mental status, oliguria, and collapse. So red flags requiring immediate care or heavy continuous bleeding, fainting, near fainting, severe abdominal pain not relieved by medication, signs of shock. So we'll have to correct the shock. Now next, coming to hyperemesis, we all know this, 26 years, I'm going fast because of want of time. So 10 weeks homemaker, severe nausea and persistent vomiting for 3 weeks, unable to tolerate any intake. Weight loss is 4 kg in 2 weeks with generalized weakness. And history of present illness, they vomited at around 6 weeks. And so no relief with home remedies associated with dizziness. And in similar symptoms in previous pregnancy. So she is tachycardic, hypotensive, dry mucous membranes, reduced skin turgor. So what will we do? Do we treat her as a daycare or admit her or send her home? What do we do?
Admitted.
Have to admit and correct the electrolyte imbalance.
Electrodes.
I wonder, Radhika, you have seen my patients because today I saw one patient. There's 3 patients I discussed, including this patient. One hyperemesis gravidarum with ketones positive. Today I admitted and gave a IV fluids to her.
Yes.
Because that is very important because they'll tell that I'm drinking water like that, but the urine protein, the ketones are positive and they give history of vomiting. They'll not drink water. That too, this summer season, they go for dehydration, and this electrolyte imbalance is more common. We see more commonly nowadays.
Yes, very good. So we have to admit them if they are ketone positive and with all these tachycardic. So we have to do the observations and document them. Even if they are sending the patient home, we need to document and keep for our sake also.
Ma'am, I would
So
like to add one point. Actually,
yes.
the current recent guidelines talks about urine ketones, that the urine ketones should not be
Ketonuria.
ketonuria is not a factor to
Not
admit the patient. Doesn't indicate the
to assess the severity also.
severity of the clinical scenario. Like this, the hyperemesis severity is not assessed using ketonuria. So if she is clinically having dehydration and the pre-pregnancy, from the pre-pregnancy weight loss, she is having more than 5% weight loss, and you see she is not able to take oral fluids in spite of starting antiemetics. It is better, and she has got any other comorbidities like urinary tract infection or associated hypertension or something like that, any associated comorbidities, you can admit that patient, but not based on ketonuria only.
So not
And
only
we need not
ketonuria is not 1 minute, Ashika. Ketonuria is not the only factor, but it is also important indicator. But that is not the only factor. So overall,
no,
the
madam,
patient.
actually, that has been taken out of the monitoring or monitoring chart of hyperemesis currently, because the recent one, I think in 2023,
GTG 2024.
GTG 2023 to 24, it tells about ketonuria very clearly, and but we need to admit the patient based on the clinical criteria
Clinical
only.
guidelines, anyway, we have to admit,
History
and
and examination is very important. When the
very
history
important, more
shows
than
that
all these
patient
things.
is having
Yes.
severe vomiting, and on examination, if she is
Skin tight girl is
dehydrated,
lost. Yes,
this is an
dehydrated.
added point. We are not going only
Point,
with the
exactly.
urine ketones.
Yes. Clinically, we can all make out actually, but we should consider those the clinical symptoms and signs. And thanks for the updating the guidelines also. So
Because
the
we are all
urine
old and
output,
you are young.
yes. And urine output also, we should, sometimes patients themselves will tell, I didn't pass urine at all since yesterday. Sometimes they'll tell, that is also an important point. Anyway, we have to treat them and then treat them, take these, the bloods for CBC and CRP also for infection, and to screen urine routine for the infections, and RFT, renal function test.
And
Yes.
serum electrolytes need to be done. And also, what I can say,
LFT, RFT.
Liver function test.
need to be done maybe molar pregnancy, twin pregnancy.
Yes, scan, ultrasound also should be done. So to rule out that. So then thyroid function test is very important. Hyperthyroidism, sometimes they can present with the
Hyperemesis.
yeah, commonest is UTI, yes. So in this case, it was a single live intrauterine pregnancy. So what are the complications? As we all said, dehydration, electrolyte imbalance, ketonuria, and weight loss. So in this case, risk of vernix encephalopathy if it's been there for more than 6 weeks due to and starvation ketosis also. So what is the management? And there is another important risk is venous thromboembolism. So when we admit them, we have to give them, apart from antiemetics, IV fluids, we also need to give them low molecular weight heparin.
And injection thiamine also, yes, ma'am.
And thiamine, yes, thiamine to prevent the vernix encephalopathy.
Avoid dextrose containing solutions.
Yes.
Start thiamine and then give.
Yes.
And in refractory cases of hyperemesis, we can also go for a short course of prednisolone also, ma'am, if they are not
Yes, very,
refractory
very
to.
intractable. Yes. The first line is Finargan, and then the second one is the Stametil, and the third usually we use is the domperidone, and the fifth one is the ondansetron.
No, madam, prednisolone.
Ondansetron and then the prednisolone.
Prednisone.
Yes, last one is the prednisolone. So we have the next case is the gravida 2 para 1 with the PV bleed, 2 months amenorrhea, excessive vomiting, passing grape-like vesicles, and per abdomen uterus is 14 weeks. Serum beta HCG is more than 100,000 or 1 lakh, and ultrasound shows no storm appearance, no fetus, and no amniotic sac. So this diagnosis
Molar
is
pregnancy.
yes. So what next? We admit them and then explain the diagnosis to the patient that it is not normal tissue and it needs to be evacuated. So we need to get an informed consent for procedure and also consent for blood transfusion because they are likely to bleed more. Again, if they are negative, rhesus negative, then we need to give anti-D after the procedure. Counseling we should do. And again, IV line and investigation should be sent. And what are the main complications we should discuss is during suction evacuation in molar pregnancy.
Risk of torrential hemorrhage and perforation.
Yes. Yes, hemorrhage is the main thing we fear, and perforation is also a main risk. And embolism can occur. That is not very common, 3 to 10%. And we should expect it after 4 to 12 hours of evacuation. Better to keep her in a HDU setup and observe. And precaution during suction evacuation. Actually, for these cases, we should not induce them. Oxytocin induction. Those days they used to give, actually it is contraindicated. So we can administer oxytocin only after cervical dilatation to prevent the hemorrhage. And that reduces the risk of perforation and anti-D is given. So post-operative precautions, monitoring blood loss post-suction is very important. Muse score, we can all use the Muse chart and watch for tachycardia. This is very important for all cases, even for normal deliveries also. Post-operative, postnatal, the 4th stage of labor, we should monitor with a Muse chart and watch for tachycardia, hypotension, treat the hemorrhage early before the patient goes into shock. So after going into shock, it is very difficult to reverse and then save the patient. So always watch every half an hour, every 15 minutes to half an hour, we need to do the vitals for all women at risk of hemorrhage. Post any surgery. HCG surveillance need to be done, monitoring for 6 months after normalization of beta HCG and barrier contraception for 6 to 12 months. And again, very important is counseling in these patients. Until the beta HCG becomes negative, patient has to avoid pregnancy. So the last case, and this is Subhatra, a 23-year-old patient opposed medical management of abortion. She expelled the POC. We went into her. She said, I have severe headache and photophobia. Ashika, Siraj, anybody? What is the diagnosis? Severe headache, photophobia.
DVT, madam.
Yes.
Most of the time.
Yes,
Raised
super.
intracranial
Pressure.
Yes, CVT. Super.
CVT, yes.
Yes, this is also important complication, rare one, but it can happen especially in summer and due to dehydration. So we should not ignore this. And again, we have had maternal deaths in India also. Last year, I think 2 or 3 years ago. So we should always remember thrombosis is also an important complication. Keep them hydrated. So any other
This
interesting?
patient also needs a proper thrombophilia workup and in the postnatal period after, because she has undergone medical management, we don't know whether it is for a missed abortion. So we need to make sure that her ANAs and APLAs are negative, and then if for future pregnancies also we need to have a plan for this patient.
Definitely. And even in hyperemesis also, we can expect this CVT. So overall, we should treat the patient as, instead of just the condition, we have to treat the patient as a whole. That is the main thing. And treatment of appropriate and timely management of hemorrhage prevents the death. And identification of ectopic pregnancies. And we should have a suspicion all the time. Any pregnancy, unless it is proved that it's intrauterine, we should think of ectopic. Thank you so much. Any points? Mona Pramila.
Ma'am, for the last minute, I would like to share one.
Ashika, Siraj. So I'd
Also
like
the
to
previous scans in early pregnancies, like for example, if we are doing the scan for the first time, we need to always correlate the findings with the previous scan and see if it is going in for a missed abortion or an anembryonic kind of failing intrauterine pregnancy. It is better to stop the progesterone supplement even if the patient wishes to come after 1 week, and if we are very suspicious about the pregnancy viability, we can stop progesterone, put her on folic acid, and then review after 7 days. That is 1 week. We can have an early review for these patients rather than keep them waiting. And because we see patients who come at 11 weeks thinking that cardiac activity will come after 11 weeks.
Yes.
So
Actually, progesterone, there is no evidence according to
there
the
is no,
guidelines.
that is because they are most of the time when we see
Injection.
patients, they are put on progesterone or sustained injections, and they come back to us with a full decidual reaction only. And when when we give medical management also, she will have bleeding and severe pain because of that. And sometimes it will not come out; it gets stuck. As mom said, it gets stuck, and we need to deal with the complications. So it is better to counsel the patient early that if there is pregnancy of uncertain viability, give her a proper cutoff that this has to be taken. If we see a yolk sac and a gestational sac, call her after 11 weeks. Otherwise, if we are not seeing anything, call her after 2 weeks to see for a cardiac activity. And if we need to set a proper timeline in these cases so that we don't delay the management.
Absolutely.
And most of the patients think that delaying scan will bring in the cardiac activity. So we need to see the right that the CRL is this much, and after this, I'm expecting this. If this is not going to happen, I'm going to terminate the pregnancy. So this is what we need to counsel the patient in the first visit. Like if we are
Pregnancy of
thinking
unknown
if it will
location, we
not
have to
go in
observe.
favor of.
Yes, we have pregnancy of
The
unknown
long period of
location.
infertility, the patient
Yes.
with repeated missed abortion and also the long period of infertility, they will not accept once we see it is not it is a failing pregnancy. So they need a proper counseling, and at least we will give a 2 days time. Don't
Yes,
immediately
madam.
I'll give
Not in the
just 2 days
first scan actually.
even if
Yeah,
I
yeah.
know
Not
that
in the
it is a
first
failing
scan.
pregnancy, yes, I'll tell her just to give me 2 days, because 2 days is not interval, proper interval. See, these are all the emotional thing what we learn from our practice. At least 5 days we need to assess the interval growth. But I will say just 2 days you wait, or I'll tell the person who is an expert scan the next door.
Yes.
I'll ask her that I have done so many scan and this is the thing and it is a missed abortion. You just tell. If they go there and come, they'll accept to some extent.
Yes,
That
he's
is
always
just
right.
ice breaking
They want a
incident.
second opinion. It's always better to send to another sonologist to get an opinion so that we can convince them better, like counsel them and convince them better for the treatment.
Yes,
Yes, ma'am.
absolutely.
2 days back, only one last case I want to share, ma'am. 2 days back, one dentist, she's my husband's relative. She's 5 weeks pregnant. UPT just positive, 35 days, amenorrhea, and she had lower abdominal pain continuously. She came to me for the first visit at 35 days. I did an transvaginal ultrasound. There was a GSAC and a yolk sac visible in the intrauterine, and the uterus was floating in the fluid, free fluid, like above, and POD full of around 200 ml. So I was in a suspicion of, but clinically she is stable and she has a constant pain lower abdomen for 2 weeks. And yes, corpus luteal cyst rupture. The amount of fluid was very huge that I got scared.
That is
And
very commonly we see, because even if it is an intrauterine, they'll tell lower abdomen. While they coming inside itself, they'll tell lower abdomen pain. And
that
we
is
also
very,
see that, yes,
that is
very
very
common
common in
point.
infertility patients, but she is conceived naturally and no other risk factors, and it was not an induced pregnancy. So that I was worried that it would be a heterotrophic pregnancy.
Actually, we had a similar case where the corpus luteal hemorrhage was in the corpus in when I was in UK, and it ruptured. Almost 2 liters of blood was there, and they had to do a drain it laparoscopically. They had to drain her to prevent her from going into shock. So that is also good. Different presentations we can see in early pregnancy, but we should have a suspicion and admit them and observe them rather than just sending them home. So thank you very much for your contribution and for your valuable time. Thank you, Dr. Subhatra, Dr. Teresa, Mona Premila, and thank you, Siraj. And thank you, Ashika.
Thank you, ma'am.
Thank you,
Points.
Radhika.
Thank you, Radhika.
Very interesting
Thank you.
panel, and we all
Thank you for the
enjoyed
interesting discussion.
very much.
Yes.
Thank you. Thank you so much for sharing.
An
And
opportunity
we
for us to share our experiences.
experiences. Definitely. Thank you so much.
Thank you.
Thank you, ma'am.
We'll-
Thank you, Radhika.
Thank you. Thank you.
Hi, Subhatra. Hi.
Hi, hi.
All batchmates, friends. Thank you, Teresa. Thank you so much. She was with me the whole time and helped. We both prepared the cases. Thank you so much.
Thank you. Thank you.
Thank you,
Thank
madam.
you.
Sujata, madam, I don't know if she's here. Thank you, ma'am. And I thank, we'll do the vote of thanks. Thank you, Sampath, ma'am. And I thank the president for TNFG, President Vidya, ma'am, and all the faculties, the chief guest and the guest of honor. And thank you, and thanks everyone for this CME.
Wonderful session. Yes. Thank you.
Thank you, Sahiti. Thank you. Sahiti. We'll close.